I'm a like hi. Too bright. How are you doing, pretty Nana? Let me probably just put this up in my little story. And invite. Ebony Queen, how are you doing? Renee, hi on YT, how are you doing? Who is joining me on YouTube now? How are you guys doing? Cutie, welcome. Thank you for joining in. How is your day going? Tina, mine is going well, you know. Mine is going well. Yeah, wasn't a busy day today. I finished working around what time? 12:30. So it wasn't bad. Wasn't bad. It was a bit cold though. It was a bit cold. Didn't like it, but finishing at 12:30, that's a plus. So I started to see my first patient at what time? Around a little after 9, probably like 9:10 thereabout. Yeah, I've started to see my first patient, and then by 12:30 I am done seeing all of them. But I only had 6 patients I saw. So that was it. Dr. Royalty, how are you? Donna, welcome. Kim, Denny, 69, welcome. Yes, it wasn't bad. I'm hoping to start a new job where I don't have to be like out in the cold, you know, in the weather now, December weather, winter weather. Yeah. BNM, welcome to my page. All right, you can always continue to scroll up. All right, and thank you for passing through. Welcome everyone. Yeah, so that's just it. But how has your day been though? Because BNM, Blake, welcome. Dear Hunter, hi. How are you guys doing? Where are you joining in from? Yeah, we have a live stream at 7 p.m. So we have our nursing live stream at 7 p.m. But you know, I haven't gotten a chance to chit chat with you guys. So I said, let me come on and catch up a little bit. Oh, you're doing good, Blake. Okay, nice. Is it cold where you're at? Is it cold? The temperature down here is what? I think about 40 something, 41 degrees. Low of 38. Not my kind of weather. But you know, dealing with it. Yeah, I am not. I am not worried about them. Okay, where are you joining in from, Blake? Which state or country you're joining in from? Miss Grace, welcome. Colorado. Okay. Hopefully one day I'll be able to visit Colorado. I'm not a snow person, but yeah. Hopefully one day I'll be able to go there. Key, welcome. How are you doing? So if you're new, oops, it's me, it's her. How are you doing? So if you're new here, I'm Stacy, originally from Jamaica, but I'm in Texas now. So I am a nurse, and I work as a house call nurse practitioner. So I spend a lot of time on the road. I'm trying to get off of the road. I love my patients. The patients that I have with this practice is really, really nice. I love them. But yeah, too much things happening on the road nowadays. So I trying to get off the road. Okay, I'm good. You have PEDS exam tomorrow. I know you're gonna do well on the PEDS exam. I think I have some about 6 questions, PEDS questions tonight. A little scenario and then some questions after. Cadence Harrington, welcome. Thank you for the floating heart. Thank you for the floating heart. So yeah, so I do host call as a nurse practitioner on Tuesdays and Thursdays. We try to do questions that should help you with the RENR, which is the regional exam in the Caribbean, and just general information for nurses, management of patients, NCLEX questions or NCLEX type questions. They're not, the ones I have now are not specifically from any of the review courses. I ask questions, I get questions, and we just go through questions. Questions can't be too much. I think the most important thing for me is ensuring that we get the concept and we know how to manage patient and we know how to save, save a life and save our license. Okay, no problem. Oops, it's me. I love how you're dedicated though. I love your dedication. Yes, I love that. I love that. But yeah, so I do that, and on my YT page, I'm trying. Hopefully one day I'll be able to do more community service, get a foundation up and running, and help out as much as I can in the community. That is something that I am very passionate about. So continue to support me. All right, show up, watch the videos, and that's it. Just watch the videos, comment, like. I know a lot of times we don't really like to like anything. We don't give the thumbs up, but eventually. So Alia is asking, do you offer private tutoring sessions for NCLEX PN? No, not right now. So with me working, well, it's not really full-time, but the amount of patients I'm seeing, I would say it's still full-time. And then getting another job, because I always wanted to work in the nursing home. The nursing home is where I really wanted to work. So I have another job that I'll be starting. Trying not to start it. They want me to start next week, but yeah, I have plans for December. I have plans for December, so I'm trying to see if I can push it down. But yeah, I'm not able to do any one-on-one right now with any student. I know persons have been inboxing me about that. I cannot commit to that right now, unfortunately. So I have small groups that we can, I can accommodate, where hopefully it will be a little bit more targeted to whatever area your weakness, because some persons are taking over the exam. So at least you'll know what area you're weak in, and we can focus on that. So if you're interested in that, it's in my bio. Just go out there. You can also direct message me, and I'll send you my WhatsApp number, and we can talk about that. But we have to arrange it and make sure it works out for both of us. And then from there, I will do the classes at 7 p.m. But I know sometimes probably the questions are not what some persons are looking forward to. And so, as I say, just inbox me and then we can have a conversation regarding it. But we will never be able to meet everybody's needs on the platform here. I think we cover a lot of information to help you with the exam. It's just for you to, use the concept, read the questions, and try to understand what it is asking, understand your pathophysiology, understand your medication, and then from there go in the exam and try to do your best. So whether or not you're getting the exam questions from Archer, you're getting it from UWorld, yes, they're gonna be similar, but you can go through as much as you can in terms of review courses or classes. If you don't understand the concept, then that is where you're gonna have problems. So you go in the exam and it's the same thing. NCLEX tutoring. So yes, we study. I prepare. I will help you with preparing for NCLEX. All right, so we go ahead and do study sessions here. Not a problem, Blake, not a problem. So you can feel free to join in. I am gonna be getting the UWorld, and then we can do smaller groups, go through mostly UWorld questions for persons who have been like, hey, can you do some UWorld? So I'll do the subscription for that, and then we can do our smaller groups. Focus on, if you want to just go through UWorld questions, we can focus on that, study in detail, just the same. But the ones that we have here on the live stream, basically still NCLEX style questions. And we just talk about the questions, the answers, the rationale, why this one is correct, why this one is not. So positive vibes, welcome. How are you doing? Oh, pin a notice for viewers. Okay, so I'm gonna pin. This is the, you can send me a direct message right now. Come on, follow up. Okay, I guess. Let me pin it. All right, so you guys are ready for the live stream tonight. Tammy, welcome. Thank you for the follow. So it's 6:35. So I don't know how many persons are here. The other day I was talking about doing the application to do volunteer services in Jamaica. Oh my word. That is a headache. It is a headache. So these are my paperwork. So the company did reach out and, you know, as I say, I was in the process of getting my nursing license renewed in Jamaica. And, yeah, it's going to cost an arm and a leg. They need to work on that because it's going to prevent a lot of nurses from not going back to Jamaica to do any service as far as I'm concerned. So this company, the volunteer service that I'm working with, is asking me to, so you know, you have to have your nursing license. Somebody was saying, just because I was saying they should have waived the fee, they should have waived the fee for renewal, just because you have so many persons who are wanting to go back to Jamaica and volunteer their service as a nurse. But if they have been out of the system for 10-15 years and they never did the correct application in terms of inactivating your license, then for the last 15-20 years that they haven't been practicing as a nurse, going back to do volunteer service is requiring them to fill out the, you know, do the regular application, which is fine. And then you're going to have to pay for all of those years of your license being inactive. Hi, Wagwan, ball striker. So, you're going to have to pay for all of that. And it's $2,000 per year, every 2 years that you have to spend to do the renewal. And not to mention that there is 120, let me look on the paper. I think it's 120 or $150. So if you're trained in Jamaica, it's $150 US. All right, for the processing fee. See it right here. The processing fee is $150, and if you were trained in the US, it's $200, and it's 21 days. 21 working days in order, you know, for the processing time. So it's there. So you have to take that into account as well, or consideration, that you're gonna have to pay that $120 or $200 plus. If you've been out of the country for the last 15 years, you're gonna have to pay roughly seven years worth of fees. So 7 times 2, that's 14,000. So that's roughly another $300. That's almost $300 to get your license reactivated. So I know a lot of persons are saying they're not doing that. You understand? Because they haven't been working in Jamaica for the last 15 years. They just want to go down and volunteer their time. And I think the government really should have taken that into consideration, or probably the government don't even realize. It's just like, well, Nursing Council. I think Nursing Council should take that into consideration, that it's going to prevent persons overseas from renewing and coming down to volunteer. Because I know a lot of persons had said that they were going to do it. But when I tell them about this application, the continuing education hours, yes, you're going to have to do the continuing education hours as well. So that's another challenge for some persons. It's not so bad getting the hours, but the amount of money that some persons are going to have to pay to do that is, you know, a bit for them. Because that is roughly almost 50,000 Jamaican dollars to renew your license. You get it back in 21 days. And then, not to mention, depending on the volunteer group that you're with, this company is asking me to fill out a professional registration for short-term volunteers. They're asking me to fill out this form, and then this form has to be filled out by the registrar, the Nursing Council in Jamaica. So they have to fill it out and then sign it and then send it back to me. And then they have another one Another form that they said that this is the application for registration as a medical practitioner. So basically, it's the medical council. I don't know if this one is really for me, but apparently it is for everybody, nurses and doctors. So this one is asking for full registration. They want an original degree certificate, certified photocopy, certified copies of academic certificates of diplomas, certificate of registration or license, certificate of good standing with registering body or valid license, name and addresses of 2 medical referees, and passport size photograph. And then this now needs to be filled out by the registrar. So yeah, form may be copied, not typed over. So all of these need to go to the registrar, fill out, and then send to the volunteer group. So it's like a headache. So the only part that I think I'm going to be doing, I'm going to try to, and then to pay the money, that's the other part, the other challenge that persons are going to be facing. Paying the money is through Bank of America, not Bank of America, through Scotiabank. So you can pay through Scotiabank, or you can pay it at the Nursing Council office in Jamaica. So I really understand how we're going to do that. I have a Scotiabank, so I'm going to be able to pay it online. But for persons who don't have access to Scotiabank, that is going to be a challenge. And then you have to bring the receipt to them. You have to give them the receipt and do everything when you're putting in the paperwork. So you have to do that. So you pay it online. You can pay it online through your Scotiabank, or you find a branch and pay it. Or you can send the money order, and then they can have their bearer go over to Scotia and make the payment. But then that is going to cost you another $50. That are just too much. Nobody not going to come down and do that. You understand? Yes, the process is just too much. It is just too much. So I know another young lady had said ODPEM, which is the Office of Disaster Planning and Emergency Management in Jamaica. She heard from them as well. And they're asking her to fill out, I think the paperwork is almost similar to this. Someone was asking about if my nursing license in the States here can be used. What I got from them is that if you're in the state and you are a Jamaican who had a Jamaican license, you have to activate your Jamaican license. They're not giving you any temporary license. The temporary license is only for persons who haven't been trained in Jamaica and doesn't have a Jamaican license. So you have to do that. Alicia, let me see what Alicia is up to. Wagwan, how are you doing? Oh, hold on. How are you?
All right, not much not going.
Okay.
I was just sitting here and I was like, you know what? I see a lot of people going live. Let me go live.
Okay. Mister, the other day I was watching your video and I tell you, I never know you were so funny. You say you were gonna change your thing there, what you're doing on TikTok. I don't think you should change it. You can.
I think I should put a professional front. You know, when people see that, they're like, "What is going on here?"
You are so funny. I never when I went over there, I was like, "Oh my word, no!" You keep me laughing for the whole time.
Well, good to know. Initially, that was the plan, but
yeah, they're funny. They're very funny.
Well, but now that you like it, I might just keep it.
No, just continue doing it. You can always continue with adding whatever else, but I don't think you should eliminate it completely. Yeah, it was really fun watching you, and I'm like, she's really a nurse because you are so much of a comedian. Oh my word. Mm-hmm. That's your daughter.
So when I went to Jamaica, 2 weeks ago?
Oh yeah, tell me about that, because I see it.
I've started my lock journey.
Oh.
So what happened? I'll tell you about it. But what happened is that since I'm thinking because I moved from I was in Louisiana and I moved here. I think the water, it's hard. Mm-hmm. So my hair kind of fell off. So it was in a really bad state.
Lamar.
So I decided to try the lock journey. So I'm on it. So we'll see how it goes. But when It's sad to say. I feel like when I went to Jamaica, the vibe that I got, it's a mixed feelings. Like you could still, see or feel the vibrant, um, how vibrant people
Or
are,
despite
and
everything.
but you could also see how stressed and
Yeah.
That they are as well. So it was a mixture. So at the airport, everybody hustling, and when I got to like I went to look for some family because they were going through a lot. But that was in Kingston, so just imagine what's going on the western side of the island.
Yeah.
But I think most people are still in good spirits.
They're still in good
but,
spirit despite everything. They're still
For the
in.
first time, I must say, my mom cooked dinner on Sunday, and she was like, "There are no vegetables. We can't get."
Funny enough, I saw a friend of mine posted. Yeah.
Yeah, I think to come. I'm hoping not, but like food security might be a problem.
It's gonna be a problem.
Hopefully not, but that's something that a lot of us should look into, or anticipate that might happen. So.
It is gonna be happening. It is gonna be happening. I saw a friend of mine posted something. I think they went down to St. Elizabeth. So in my mind, I know that a lot of places in well, based on where the hurricane passed through, is like total destruction. But they showed where somebody had a farm, and you could see the thyme. I don't know if there was scallion, and it was so green and beautiful. And I was like, oh my word, this is St. Elizabeth I knew. You understand? All the other photos that I'm seeing is.
Give me a second. My son decides to please.
Okay. So I contacted OddPem, but no date yet as to when they need the next set of volunteers. Fifi Brown, okay.
Don't mind the boxes at the back. All right, say hello. I don't know. Say hello or hello. We're having a mess around.
Fire, what's up? Okay, so Raquel here is saying, I got an email and list of documents to fill in. The tasks seem tedious. Yes, that's the same thing I was going through a while ago, Raquel. It is a lot. It is a lot. So right about now, I feel as though I would want to just get my license and just go down, because all of this thing is just too much for me. It's just too much. I feel as though I could just pay the money, ask somebody to go and do the paperwork, finish up the paperwork for me, and just have a license. Whenever I go to Jamaica, I go to Southern Regional or the Ministry of Health and see if they need my help, and I can do that. But the only thing about it is that with a volunteer group, you'd have a more structured program, you understand? And not only that, based on where they're gonna need you, they could have housing for you there. Because me living in probably 1 hour, 2 hours away from the areas that they need assistance, it's gonna be a challenge for me down there. So that's why I really wanted to sign up with a volunteer group. But this is just too much. It is just too much. So you see me fold my paper right about now. I fold the paper and put it one side, and I say, no sir, I really want to help, but it's just too much. It is just too much. I saw you the other day, Alisa posted something. Were you doing like a volunteer? Were you doing donations or something, assisting with donations?
Yeah, so I think I started kind of late, but I was asking, I tried Facebook and some like family and friends, TikTok, and I reached out to people asking if they had any donations. However, I got like 3 suitcases and I think like 5 boxes of new shoes and slippers and clothes and everything. So when I went to Jamaica 2 weeks ago, I was able to I didn't ship that. I didn't ship them because I think the wait time, and I was going to be there for like a short period of time.
So
So what I did was to just pack them very well and took them to the airport, and we were able to take those things to Jamaica. But I was hoping to deliver them myself, because I had also planned to do like a little cookout or something.
So we need to link up, because that's what I really want to do. I want to help with something.
My flight got delayed, so I lost like 2.5 days.
Ouch.
So that cut the time short. So I wasn't able to do that, but I think we should definitely link up. And I was able to donate what I had to an organization. Well, my mom told me about it, so we dropped them off, and then I came back. But I was fortunate. Luckily enough, I went on Facebook and I saw them, delivering, handing out some of the stuff that I gave them. So, and they sent me like a thank you for donating note. So I was able to send that to
the person,
the organization here that gave me all of those things. So that was something, that was really nice.
Okay. I think a lot of persons are past the phase now, though, for the handout kind of vibe. Yeah, I think people want hosts now. Them need hosts. I mean, I agree with the Prime Minister. Nothing is wrong with the handout and everything, but yeah, I think they're kind of, yeah. Yeah, but housing. That's I think it's costly. Let's say. Yeah, it is.
So I think people are just trying to do what they can, even though we know the need is housing.
I know. But I think, with everybody now with social media nowadays, I think we feel as though, I feel as though we kind of using this thing for views. We're using it for views nowadays, and this hand me out thing, me not really like it. The handout thing, me not really like it. If you got handout and take it off of the, nobody put it on social media. I think it's more for views, and that's just it. I'm gonna really like it because a lot of persons,
I'm thinking that, there are some people who are like coming out saying this person or, popular figures in Jamaica are not doing enough. They're not doing this. So I think that's why a lot of people are like putting it on social media. I don't agree with it, but I think they're like, hey, you're saying that we're not doing this, but I don't know.
Yeah, I really like it. Some of them.
Personally, I don't really care if I'm on video or not. So, but I guess it's important to some people. So we'll see.
Yeah, I'm kind of 50-50 on it. Kind of 50-50
see how I come take over your life. When you're ready for me, go, you tell me,
Me so tell if we go. If we go now, because 7 o'clock, my folks are waiting. They're patiently waiting for 7 o'clock for my live stream for NCLEX. Well, nursing study. We're not gonna say NCLEX because it's
Man, you've been doing a great job, so keep it up.
Thank you. It's like a receiver. Exactly, positive vibes. So yeah, but we'll link up though. I really want to talk with you regarding some stuff for that.
All right, sounds good.
All right, yeah, man. Later.
If you can take me off. I don't know how to get out of here.
All right, later.
Bye.
All right. I hold this going, dear Father.
Put the violin down. Put the violin down, please.
Alicia, I don't know if to take you off.
Let me see. Shit. Put the violin down. Oh boy. I need to get out. Let me just
Huh?
All right.
I don't know how to. I don't know how to do it. Okay. So yes. Sorry about the noise. Kids are playing their instruments. So that's all. Life of being a mother. Technology, I don't know either. Yes, I don't know what to do with that. Brittany, you're here for 7 o'clock. You're here for 7 o'clock. You're early. So that was just it. What I'm saying, the process for this volunteer Getting the license and everything is just too much. I just feel as though it's too much. I did send nursing council a message from when, and that's Nursing Council of Jamaica. I sent them a message asking them about waiving the fees and everything, so at least more persons could be, you know, willing to come down and assist. Because even if they're not going to be doing it through a volunteer group, at least they can come down on their own time and just show up to one of those regional, you know, head office and say, hey, I have an active license. They will find place and put you. So I sent them a message on WhatsApp from when was that? Nursing Council, see there? November 26th. November 26th, I did send them a message on WhatsApp. And all no, but not answer the message. Not at all. Yeah. But that's just it. That's just it. Lamar, forever under. Who is joining me for the first time? Who is joining the live for the first time? Here, I know positive vibes always here. Brittany, Brittany, Sassy, Fifi Brown. Fifi Brown, where do I know you from? Can you say something the other day to me? You know, may I say where I know you from? I don't know if you're still here. Where I know you from? Hold on there. So you can speak directly to Dr. Heather Fletcher. She's in charge there now. Okay, I don't know Dr. Fletcher is up there. I don't have Dr. Fletcher number. You are so NCU. The only Fifi Brown me I think about is I don't know, no, Fiona? No. Is this Fiona L? Fiona! Oh my word. When I see Fifi Brown, the only person that came to my mind is Fiona L. You know, yeah. Bacchus, how are you doing? Yeah, you're the only person that came to my mind when I see Fifi. And then when you said something, I'm like, okay, then NCU. But then I say, all right, then you know what? I don't think it's Fiona. But it's nice seeing you though. Well, not really see you, but we will link up again. Lamar, warm to you. Why you always come on the chat and just talk all of them stuff here? Why not ask me something about nursing? You work real hard for time out, you know. You working really, really hard for time out. I never put you on time out the last time. But anyways, it's 6:58. It's 6:58. Yes, positive vibes. I'm working really, really hard to go in time out. Yeah, man. The last time I come on the chat is the same thing. I'm say, you know what? Just I'm gonna give you a few more minutes. And today I'm come back again on the same line, the same storyline. 7:58 here in New York. Okay, it is 6:58 for me here in Texas. All right, let me turn on this thing and we'll do a few questions and then from there. But welcome everyone. Remember to go ahead and subscribe to my YouTube page at ThinkNursing, one word, the same as the handle here on TikTok. So the full live streams are, you know, on that platform. And yeah, and I post other contents over there as well. So feel free to go over there and check it out. If you want to know a little bit more about me from, you know, apart from what you see on TikTok here, everything is posted on YT, on YouTube at ThinkNursing. So, all right, let me get this up and running. Fiona. I never tell you, no, but I tell you now that I did miss you. Yeah, I did miss you. Fiona and I used to study. Yeah, we used to study together in college. Yeah. It's been years. Years. It has been years. All right, let me get this thing up. Okay. So we're gonna do some management error. So we're gonna spot the error and then we correct it. The management, we'll talk a little bit more about it. We'll also do, I think we have some pathophys question mixed in as well. We also have like a scenario, and then there are about 6 questions that we will answer. Select all that apply. And yeah, we'll have fun while we're studying. Thank you, Fifi. We will have fun while we're studying. All right, so I'm going to turn the camera so we can start for our 7 o'clock live stream. So I'm going to turn the camera. George, welcome. How are you doing? All right, let me fix this one. And as I said, pathophys is very important. So you might realize that a lot of questions are around pathophysiology, because I just feel as though if you don't know pathophysiology, as me say in Jamaican, dog name your supper, which mean, you know, it's going to be difficult for you to understand anything when it comes down to the management of patients. So you have to go ahead and get your pathophys. And once you're able to do that, you will know what is going to be your priority, what is going to be your first action. And from there, you save your patient life. Grace to me, welcome. Good night again. Oh, we haven't catch up, Grace to me. Have you finished CRNA school? Do you finish CRNA school? Because we're going to have to be bigger friends, you know, because I see a gentleman posting paycheck the other day, 2 weeks salary, a 2 week salary. And me see the gentleman say work $20,000. Grace to me? Oh, in 2027? Okay. Oh my word, $20,000. So guess what, lady? We are gonna be even bigger and better friends. But just messing around. But that is nice though. I'm happy for you. All right. So I love your review. I love your review because it helps me remember some stuff that forget back in school. Oh, hold on there. Yeah, so it's not only for students. It's not only for students. Everybody will be able to benefit from it, from the study session here. Because I'm learning as we go along. Because some things that I learned in nursing school, I haven't seen them in years until some students are asking the questions on the live here. Yes, Grace to me, it's a lot. It's a lot. When you finish, you will be experiencing it. You will be experiencing it. So just continue to stay focused and keep motivated. And all the other persons that are out there, and this is something that you want to go and do, you know, advance yourself. Advance yourself. Okay, no problem, Fiona. No problem. All right. So as I said, this is not a multiple choice question. Basically, I'm just pulling your memory. See what you know about, the different conditions here. I think we have about 10 questions. I have some respiratory and some cardiac questions. So basically, you have a patient that is having acute asthma attack. The error is that the nurse gives inhale corticosteroid first. How do you manage this patient? What is the first thing? If you have a patient with acute asthma attack, what is the first thing you'd give this patient? Is it corticosteroid or what? What is the first thing you'd give a patient with acute asthma attack? Fulu, first time I'm seeing you. Welcome, welcome. Thank you for tuning in. albuterol. Budgeting with Crystal, welcome, is telling us to read Job 6 verse 14. Anyone who withholds kindness from a friend or forsakes the from a friend forsakes the fear of the Almighty. Job 6 verse 14. Albuterol, nice. Okay, and we know that albuterol is what? What is albuterol? What kind of drug is albuterol? We need to open up the airway for the steroid to work. Correct, Eden. What kind of drug is albuterol? I see here vasodilator. Is it a vasodilator? Beta 2 agonist, bronchodilator. I'm always here. Oh, you're always here, Fufu? Oh, you're just in the background. Okay, okay. Thank you so much for tuning in. Beta 2 agonist, nice. So you give your albuterol first and then you give your steroid after. All right, and that is for your asthma, your asthmatic patient. Status asthmaticus. The nurse gives opioid for anxiety. Is that okay? What do we know about status asthmaticus? No, it's not correct. So how do you manage status asthmaticus? You have a patient that is in status asthmaticus, or how do we define status asthmaticus? So risk of respiratory compromise, yes, Eden. So it seizure lasts longer. Risa, seizure. Forever blessed. How are you doing? It's been a while. Yes. Tidun, welcome. Intubate. Okay. Thinking about intubating. Risa says its seizure lasts longer than normal. See, I'm trying to figure out. Risa, type it over again for me. Type that over. So you're talking about status asthmaticus here. What is status asthmaticus? It's life-threatening, not responding to any bronchodilator. Yes, so you have life-threatening asthma attack. It's an acute severe asthma. Anyone on YT? Okay, so yeah, so when you're treating, you're giving those medications, the standard medication, like, you know, multiple rounds of your albuterol, the patient is not responding, then the patient is progressing to having severe airway obstruction. So that is where you have your status asthmaticus coming in. So you've been giving your albuterol, those bronchodilators, and it's not helping with their asthma. They're having the constriction, bronchoconstriction going on. So the patient is progressing into status asthmaticus. They don't respond to the medication. That's what, yeah, yes, Grace, to me. I know she's talking about status epilepticus, but I wanted her to correct herself. I wanted her to correct herself, but I don't see her typing it here. But I know she's talking about epilepticus here, but I wanted her to type it in again. I wanted her to type it in. So if you have a patient that has status asthmaticus, not responding to your, your regular medications, your bronchodilators, what is it that you're thinking is going to help with this management, the management of this patient? What are you anticipating? So this patient is, I totally forget that I need to touch the screen or else this thing is gonna, high flow oxygen. So intubation, you're eventually gonna be intubating this patient. So no opioids needed, give the bronchodilators, your IV steroids, and prepare for intubation. So when you think about your status asthmaticus and you have, you know what's happening in terms of the pathophysiology, then that will help with guiding you into how you go about with managing this patient. You continue nebulization. So as I say, you've been given the nebulization. You'll eventually give the nebulization via the, the vent. You'll continue with that to help with opening up the airway. But if you're giving repeated doses of albuterol and it's not improving, the patient is going the opposite direction, then, definitely you'd want to prepare this patient for intubation. COPD exacerbation. The nurse put 6 liters of oxygen via nasal cannula immediately. This patient is a COPD. How do you manage this patient? That's the error. So she puts on 6 liters of oxygen via nasal cannula. Is that okay for that patient? No. How do you go about with managing? So the patient has 6 liters of oxygen now. How are you going to be managing this patient? You're the nurse that comes on to the floor. You're taking charge. What do you do? So they're giving too much oxygen for the COPD. Okay, yes. Sasha Grace, welcome. So 2 liters max. Risa is asking. You give them the 2 liters. So you drop their oxygen to 2 liters. You'll give them your Duonebs, your albuterol, and your steroid. Atrovent, whatever else they order. So this patient is at risk for what? So this COPD patient is on 6 liters of oxygen. What is this patient at risk for? You have a patient that has COPD, is on 6 liters of oxygen. What is this patient at risk for? Curvy, welcome. Elaine, welcome. Hypercapnia, respiratory failure. Nice. CO2 retention, CO2 narcosis. Yes. So this patient will eventually start getting, very drowsy. So you have to make sure that you turn this oxygen level down, and then from there, manage your patient. So start with 1 to 2 liters. You titrate slowly to because of the risk for CO2 retention. Yes, that's too much oxygen can lead to respiratory acidosis. So if this patient is in respiratory acidosis, what system is going to be compensating? If you have a patient that is in respiratory acidosis, what system is going to be compensating for this patient? The renal, kidneys, grace to me, yes. Serotonin, welcome, welcome. SCT says your nose. Oh, no. So the one that is compensating is your kidneys. All right, nice. You have a patient that has pneumothorax, but the patient is now in a flat. The patient is placed in a flat position or supine position. The patient is in a flat position. How do you fix this problem? So you have a patient with pneumothorax. The patient is placed in a flat position. How do you correct this management? Yeah, Sasha Grace. Fowler's increase breathing. All right, apart from Fowler's position, elevate the head of the bed. What else can you be doing for this patient with a pneumothorax? Have him run. Sit. Okay, so we're finished with elevating the bed and the high Fowler's position. Yeah, we're finished with that. What else can we do for this patient? Sasha is asking chest tube. Yes. Think about a chest tube. You need decompression, leading novation. So you say needle decompression. Are you, which of the pneumothorax are you thinking about for your needle decompression? Because if you have a COPD, a patient that, you know, just have a spontaneous pneumothorax, are you going to be doing a needle decompression? No, you do it on a tension pneumothorax. Nice. So you have a patient with pneumothorax. You plan for this patient. Get a patient in high Fowler's position. Oxygen on, prep for chest tube. And that's how you go about with that management. Get tension pneumothorax here. The nurse waits for chest x-ray. So you have a patient in chest, with tension pneumothorax. You have a nurse there that is sitting down waiting for the patient to get a chest x-ray. How would you manage this patient? What would you do as a nurse taking over? Oops, it's me, it's her, the needle decompression. But the doctor ordered the, you know, the doctor said him need a chest x-ray, him need a chest x-ray. So what are you going to be doing? The decompression, definitely. Because while you have this patient with a tension pneumothorax, what is going on in a tension pneumothorax? What are some of the signs and symptoms of tension pneumothorax? Because this is a medical emergency. So what are some of the, you know, the signs and symptoms or the classic signs of tension pneumothorax while you wouldn't be sitting down waiting for a chest x-ray? Deviated trachea. Tracheal deviation, unilateral breath sounds, respiratory distress is enough to intervene. Yes. Diminished breath sounds, plumb vein, nice. Jugular vein distension. Exactly. So with that patient there, that patient can't be waiting for a chest x-ray. That patient cannot wait for a chest x-ray. If it was like, you know, if it was just the pneumothorax, then, you know, depending on what is going on, you could say, okay, they'll be waiting for the chest x-ray. But with a tension pneumothorax, you know, that is a medical emergency that needs to be, you know, sorted out immediately. So emergency needle decompression is needed. So that is what you'll do. We won't be sitting around waiting for any chest x-ray. Can get chest x-ray after you do your decompression. Chest pain, respiratory distress, yes. You have a patient with pulmonary embolism. Your nurse is encouraging the patient to ambulate to improve circulation. So you have a patient with pulmonary embolism. Your nurse is encouraging the patient to ambulate to improve circulation. So remember, this patient, you know, has a PE. Oxygen is low. We need to improve, you know, the flow of the blood. Oxygen to, you know, to the lungs. Dislodge clot, blood clot. Risa says dislodge blood clot. Yes. Where is that blood clot? Where is it dislodged? In the brain. In the leg. Where do you have the pulmonary? Okay, in the lungs. Yes. So the nurse encourages ambulation to improve circulation. No, we're not going to do that. So it's in the lungs. Most common location, or, you know, for your clots is in your deep vein, your DVT, and most of the time they get dislodged. So for this patient with a PE, If the patient is encouraged to ambulate, what are you going to be doing as a good nurse? Good up nurse that come on the floor. What are you going to be doing? Strict bed rest, left side Trendelenburg position, nice. What else can you do for this patient in the meantime? Put on a little oxygen too, you know, put on a little oxygen. Ensure that they have the DVT stocking, blood thinners, oxygen. Grace to me. Just messing around with the restraints. Yeah, no restraint. So your oxygen, blood thinners, bed rest, left side Trendelenburg position. Nice. So your PE patient, we're going to do your bed rest, your oxygen, anticoagulants, notify your provider. So Rose says warfarin. In the inpatient setting, like initial, like, you know, the initial management, you'd want something more IV, and then, you know, when you're planning on discharging, eventually they will get them on like warfarin, Eliquis for discharge. So you'll go with your heparin, or, you know, per order, and then from there. What is the antidote for your heparin overdose? What's the antidote for heparin? Protamine sulfate. Protamine, yes. And what labs do you monitor for your warfarin? What labs do you monitor for your warfarin? PTT, APTT. INR. So yes, your INR for your warfarin, and lead innovation, your PTT for your heparin. Remember that, all right? So your warfarin is your INR, and your heparin is your PTT. Okay, good. This patient has pneumonia, but the nurse is delaying antibiotics until she gets the culture results. Do we wait for culture results to come back before we start antibiotic? Broad spectrum in the meantime, no. Users 4726, good. No. Moochie, welcome, welcome. No, you never delay, you know, your antibiotics because you're waiting on any blood cultures. It's the same thing. If you can't get the blood, you go ahead and give the antibiotics. So for this patient, delaying antibiotics until blood culture results are have returned, what you'll do, you'll go ahead and start your antibiotic as per RISA. Nice. Okay. So go ahead and start your antibiotic per order. In terms of your patient, you're working up this patient for pneumonia. What are some other things you'll do as a part of the management? What are some other things you can do as a part of the management for this patient? What are you expecting? You're working this patient up for sepsis, pneumonia. What are you going to be doing? Okay, frequent sips of water. So fluids. If you're doing the sepsis workup. Oxygen, if their oxygen saturation is a problem. So if their oxygen is a problem, then you address that. But if their oxygen is fine, you don't need to put them on any oxygen. What else? You're working up this patient for sepsis. What are you going to be doing for your patient? Physiotherapy. Okay. Yeah. What else? Monitor vitals. Oxygen, deep breathing exercise. What about labs? Monitor temperature, antipyretic. Yes. I'm waiting for my labs. So what labs are we getting? What labs are we getting? Infections, fevers, maybe fluid. Yes, fluid. Not really fluid retention, unless the patient is like a CHFO. You want a CBC, you want your white blood cell or CBC with differential. ABG Chem. So your basic labs. Incentive spirometry. Yeah, eventually for your pneumonia, depending on, you know, the severity. BUN creatinine. Why are you getting your ABG on this patient though? Why are you getting ABG on this patient, Monique? Why would you get ABG on this patient? Yeah, Cabra, why are you getting blood gases on this patient? But like in, you know, you're working up this patient. Respiratory acidosis. Okay. But in terms of like basic, I just want like basic labs that you'll be doing. So like your lactate, I haven't seen anybody says your lactate. So like your lactate to CBC, you know, CBC, CMP, you can get your urine, you can get your lactate, your blood cultures. Those are like the basic, unless something else is going on when you get your electrolytes, then you can be like, okay, then we can go ahead and get additional things like your ABGs. But usually as a part of like your routine, that's not something you're gonna run and get at that time. So I was just wondering. So it depends on what's going on with the patient. But if they say routine, you just get your regular like CBC, CMP, your lactate. Your lactic acid is very, very important. And you get your fluids going, your antibiotic. If you can't get your blood, you just go ahead and hang your antibiotic because that is important for the patient. All right. So draw your cultures and start your antibiotics ASAP. Most of the time, it's going to be broad spectrum antibiotic. Once the culture results are back, if that antibiotic that they gave initially is not covering whatever bacteria is seen on the, you know, on the culture report, then they will go ahead and administer something else a little bit more specific for that bacteria. So you have a patient that has acute respiratory distress syndrome, ARDS. The nurse is giving large IV fluid boluses. What would you do for this patient? So you're in charge of this patient and you see that this patient is getting large IV fluid bolus. What are you going to be doing for your ARDS patient? Thank you for the follow, guys. Slow the rate, Mushi. Nice. What do we know about ARDS? What do we know about ARDS? ARDS. It will cause fluid overload, shock, lungs, yes. Reduce volume, monitor for pulmonary congestion, risk for pulmonary edema, yes. So if you see that this patient is getting large fluids, fluid boluses, you want to cut down on the rate for this fluid. So you restrict your fluids and you increase your PEEP and your mechanical ventilation. PEEP is what? Positive expiratory. Grace to me, help me here. PEEP is positive expiratory pressure. PEEP. Positive. Let me look it up. So basically the amount of pressure in the lungs at the time of exhalation that is needed to open. Yes, positive end expiratory pressure that is needed to open up the alveoli. So they need that So you can actually have, you know, the flow of the gas, proper gas exchange taking place, basically. So that is what PEEP does. So positive end expiratory pressure is the pressure applied by the ventilator at the end of exhalation to keep the alveoli open. It prevents alveolar collapse, improves oxygenation, and is commonly used in ARDS, severe pneumonia, and other respiratory failures. So when you go into ICU, most of the time you will see your nurses or your respiratory therapist. They'll be doing all of that on the vent. So you restrict your fluids. Recruitment. Cabra. Sasha, thank you for the gift. Thank you. So that is what you'll do for that patient. If you notice that they're getting too much fluid, you cut down on the fluid. Are they always sedated? The jamming Elenice is asking if they're always sedated. When they're on the vent, you're asking, or just a patient with your ARDS in general? So patients on the vent, are they always sedated, class? So the Jamins is asking, think about it, Jamins. You have a patient that is on a ventilator. Just think of it. Just think of it. Just think of what is going on with a patient on a ventilator. So yeah, they're always sedated on their, you know, on their ventilator. They'll be on a lot of pain medication as well, because that thing in your throat, the ET tube, is very, very uncomfortable. So they're gonna be sedated. Yes, they're intubated. Just think of a ventilator and what is happening. You have a long tube in your trach. So they're going to be very sedated, because just imagine having something in your throat. It's going to be very, very uncomfortable for you. So that patient is going to want to start pulling, you know, getting that out. So you have to get them very, very sedated and very comfortable. Not a problem. So you have a patient that is at risk for aspiration, and the nurse is feeding the patient lying flat. You get that patient in high Fowler's position. Okay. So initially, yes, once CPR, cardiopulmonary status improve, they are weaned off in periods of break where we cut sedation and see how they do. Yeah, but that is at a time when you're trying to probably extubate them, thoracostomy, right? So stop feed, high Fowler's position. Stella, welcome. 60 to 90 degrees, yes. Small bits, exactly. So you elevate the head of the bed 30 to 45 degrees. Then you go ahead, you do small, you know, small, soft, pureed food, things like those. Before you even do your before you even feed this patient, a patient that is at risk for aspiration, what is one thing that you definitely need to do before feeding this patient? Well, already said we're going to put the head of the bed up. What is one thing that you want to document before you start feeding this patient? If you have a patient that is at risk for aspiration, a swallow evaluation, check their gag reflex. Yes. I thought she asked if they are always sedated. Oh, yes. That's what she had asked, Grace, to me. So you want to go ahead and make sure you check the patient if they're able to swallow. So make sure you do that swallow evaluation and document it, and then you can go ahead and feed. Cabra is saying, but they are on tube feed. Not all the time. This scenario just says the nurse is feeding a patient lying flat. So this patient is lying flat. It didn't really say it's a tube feed that is going on. If the patient is, if the patient has a tube, then you will just go ahead and do your necessary checks and make sure you still have them in that position. Because regardless of it being tube feeding, the stomach is you're gonna have that reflux when they're lying flat. So you still have to put them in that position to prevent any backflow of the feed. So you have a TB patient. The nurse wears a surgical mask to enter the room. You need an airborne N95. Yes, it's airborne. Tube checks if they're on it. Yes, do your tube checks. So get your N95. Will this patient be in the hallway? This patient will be with another, another patient in another room. Negative pressure room, hopefully. Yes, negative pressure room, private room. Surgical mask for patient leaving the room. Okay, yes. So definitely get your patient in one of those isolation room, negative pressure. You go in with your N95. Your N95, and then from there, you care for the patient. Never put them with someone who is immunosuppressed. As in the nurse or the patient with a nurse. Because most of the time, you're not going to want to put them with any other patient. Unless you have a ton of TB patients in the hospital, then you can put them on a TB floor. If that is a designated TB floor. So negative pressure, isolation, yes. So you use your negative, your N95 respirator and your negative pressure room. So make sure when you guys check into the hospital, when you start working, you know what N95 you wear. So you can always have it readily available. Because sometimes the ones that the hospital provide, it might not be suitable for you. You might not pass the fit test for that. So you want to make sure that they have the type of N95 that you are going to be wearing, or else you can't go in the room. You cannot take care of the patient. So make sure that you do your fit test and the hospital is providing or has it. So whenever you need it, you can use it. Or else you're going to, just excuse yourself from that patient. So always do a fit test too. Yes. The patient with crushing chest pain, the nurse delays giving aspirin until after labs. I know aspirin is something that, most of the time we'll be like, oh, it's just aspirin. But what do we know about aspirin as it relates to chest pain, ACS, acute coronary syndrome? What do we know about aspirin and its effects or the benefits to the patient in chest pain? What it does. So it needs to be given. Why it needs to be given? Apart from because it's a doctor's order. Why you need to get that going for the patient? It's a blood thinner. It improves circulation, bleeding. So prevents clot formation and improve the viscosity of the blood. Nice. So it's an antiplatelet. Let's see. What's this? So you need to give the aspirin to prevent, those platelets from more oxygen to myocardium. Yes, from clumping together. All right, sticking together and worsen that clot formation. So you need to get it to the patient. So for these patients, what's the aspirin dosage you're anticipating? What is the dosage you know that we normally give for your aspirin? So you give baby aspirin. How much of the baby aspirin? So this is 325. Can be anywhere between 172 to 324. 325 thereabouts. So as long as they have the, you know, the 172 to 324 milligrams, then that is pretty good for the management of your bit size blessings. Is 324.789. Yes. So anywhere between there is safe for your chest pain. Yeah, that's it. Anywhere between there is safe for your chest pain. So you go ahead and make sure that they take it. Do you have them swallow it or do you have them chew it? Which one is the best route for this patient? Okay, Sasha says chew. Why do you give them to chew, Sasha? Why chew it? This patient is having chest pain. Why not just go ahead and swallow it? Just tell them to swallow it and get it out of the way. They're going to have to chew on it and then it's not going to taste good and, you know, it's just going to be too much. Why you want them to chew on it? Why you want them to chew on it? Stella Niki says sublingual. Bite size. Breaks. Okay, so quicker absorption like some other medications. It works faster. Fast absorption to be placed under the tongue. So Moochie, are you gonna put the 4 tablets under the tongue like nitroglycerin, or are you gonna have them chew it up? Are you having them chew it, or are you gonna have them put the 4 okay, nice. So they chew it up, and then from there. So nitroglycerin is sublingual. What if they don't have teeth? I normally crush it. So I'll have the bite size. You know, I ask that question. I normally crush it and just put it in. And then just get a little small amount of water. And then just put it in their mouth. They left their dentures at home. Yeah, they will eventually, you know, just crush it. And just put it in the side of their mouth. Use your hand and, you know, your finger and just rub it in the mouth. And just put a little bit of a water there. That's how I do it, to help with softening it. And then hopefully they'll swallow it. So just go ahead and do that. But I don't put the 4 tablets or the 3 tablets, because those are pretty decent size. Not nitroglycerin. Those are pretty decent size aspirin. So don't go ahead and do that. Unless they now have sublingual lunges, crush and in water. Yes, but you don't want to put it in too much water, because remember, this patient is NPO. You're going to NPO this chest pain, so you just need enough water to dissolve the medication in the mouth. So that's why I say I just usually use probably like 1 ml of water and just put it in the side of the mouth. Use my finger and just a bit on and just put it in. Most of the time, we don't have spoon in the emergency room. I'm from the emergency room, so we don't really have spoon like that readily available. So I just crush it, you know, crush it on the table, take it up, put it in the corner of the mouth, tell them to swallow, and continue. Oh, bit size, your specialty is OB. Okay, nice. Yeah. So you go ahead and never delay giving your aspirin because you're waiting on your labs. And why would you delay your aspirin because you're waiting on your labs? Why? Oh, probably when they're drawing the samples, I'm thinking. That is the only thing. Yeah, but ride and whistle. A lot of times you'll have a lot of persons coming down at once. They're swarming the patient when you have your chest pain. So somebody will be getting medication. Somebody will be getting blood, EKG. So, you know, you don't need to delay anything. But never delay your aspirin. The patient needs it. That is something that is very important. So delaying antiplatelet therapy is the error. So give the aspirin, the chewable aspirin, immediately unless contraindicated. Early aspirin reduces platelet aggregation in suspected myocardial infarction. Kind of like don't wait for labs to give someone blood who is actively bleeding. Exactly, bite size, exactly. So unless the patient says that they are allergic to aspirin, then you know we step back. And you're not going to give that. A patient in VFib, ventricular, hold on there. VFib, ventricular fibrillation, VFib. Yeah, that emergency. What is that one again? No, not DFib. VFib. Ventricular fibrillation, right? You see, that's a long time in the emergency room. It's like I'm here and I'm like, ventricular fibrillation. Okay, so you have a patient in VFib, ventricular fibrillation. The nurse shocks once, then waits 5 minutes without CPR. What is it that she did wrong here? So you have a patient that is in VFib. What kind of rhythm is VFib? What kind of rhythm? Is that something that you can hang around with, or is it a lethal? Is it a... Okay, so she waited. So Sasha says sawtooth. Is VFib a sawtooth rhythm? Is VFib a sawtooth rhythm? No, it's not a sawtooth. Sawtooth is your flutter rhythms. Squiggly, yes. Enrig, it is a squiggly, the little fine, tiny ones. That is your VFib. So the flutter is the one that looks like the sawtooth. Okay, so the patient is has a lethal rhythm here, and the nurse shocks once, then waits 5 minutes. Do we wait 5 minutes? Yeah, there you shock the patient once and you say, okay, let me go on TikTok. Okay, let's see what's happening over here. And then 5 minutes later, you go back to find out what's happening. So you get the defibrillator, follow the instructions most time, and continue CPR. I thought pulseless VTAC was something. Oh, your patient is dead and the nurse is fired. Exactly. 5 minutes could be too long. Resume. So you resume. So the problem here is that she waited, or he waited 5 minutes. So you don't pause in between. All right. You don't pause in between your shocks. Resume high quality CPR immediately between defibrillation attempts per your ACLS. And then this is, you want to make sure you're minimizing interruptions to maintain perfusion. So waiting 5 minutes, that patient is going to be, in a body bag in 5 minutes. You need to do high quality CPR for this patient. You have a patient with acute chest pain that is given nitroglycerin, but blood pressure is 80/15, 80/50, but the nurse gives it anyway. Fired the nurse again? Okay. So you have a patient that is having acute chest pain, is given nitroglycerin, but the blood pressure, what is the problem here? What is the problem with this patient? So you see that the blood pressure is low. The blood pressure is low. What is a good reading for your blood pressure before giving nitroglycerin? So what is an acceptable reading? What is it that you're looking for before? 90/60 leading ovations. Nice. So once it's above 90/60, you can go ahead and give your medication. If you have a 90/60 for your blood pressure here, and you're going to be given nitroglycerin, what other thing you can go ahead and do for this patient to prevent the patient's blood pressure from dropping too far? So you have a patient that is, the blood pressure is 90/60, but this patient is actively having chest pain. What can you do in the meantime to help maintain that blood pressure while you give the patient the nitroglycerin? Because you know that 90/60 is low, not really low, but you don't want it to drop any further because of the vasodilating effect of the nitroglycerin. Good. You go ahead and give your IV fluids. So get your IV, start your fluids, give your nitroglycerin, and recycle your blood pressure. How often are you going to be recycling your blood pressure or checking your blood pressure after your nitroglycerin? Check it you're checking every so you can give the every 15 minutes. So you give the patient the nitroglycerin. You're going to give the nitroglycerin 3 doses, or how many doses of nitroglycerin can you give safely? How many doses of, okay. And then, yes, you do every 3 minutes, every 5 minutes with your nitroglycerin. Then you will go ahead. So you have 3 medications every 5 minutes. You have 1 tablet every 5 minutes. So for over 15 minutes, the patient would have gotten the three tablets. So then you're checking blood pressure every 5 minutes. You're checking your blood pressure. You're checking your blood pressure before each dose. Yes, Stella, 3 doses every 5 minutes for 15 minutes and check the blood pressure before giving each dose. Yes. So you'll go ahead and do that. So you know that this patient got the nitroglycerin. Blood pressure is already low, but the nurse went ahead and gave it. So we know that it's going to even drop further. So the problem is that the blood pressure is too low. So giving nitroglycerin with hypotension. Giving nitroglycerin with hypertension is a problem. Hold your nitro if the systolic blood pressure is less than 90. Notify your provider and treat for shock first. Nitroglycerin can worsen your hypotension. If they're in the hospital, send them to cardiac catheterization lab if things don't change. Okay, well, it says they're caring for the patient, so the nurse ain't hanging in their house. Okay, so you go ahead and get your nitroglycerin going. So for example, you give this patient the nitroglycerin, 3 doses of nitroglycerin. The patient is still having chest pain. What else can you do for this patient? What else can you do for this patient? In the meantime, what are you anticipating in terms of medication? Okay, yeah, you already give the patient oxygen. You already, all right. The Jasmine says vasopressin. Why are you gonna give this patient vasopressin, Jasmine? So the patient is having chest pain. Patient is having chest pain. You already gave the nitroglycerin. You're going to be giving vasopressin. Why are you going to give the vasopressin? Patient is getting fluids, blood pressure, you know. Okay, raise the blood pressure. Okay. But the patient is still having chest pain after 3 nitroglycerin tablets. Okay, patient already got the EKG. The patient is having chest pain after, I know some person says that Mona doesn't exist or they don't use Mona anyway anymore. Okay, lead innovation. What analgesic are you anticipating? So you've already given the 3 nitroglycerin tablets. The patient is still having pain. Your patient is on fluids. And that's what I was told, Jessica, but I know that we're still doing it. The other day, some persons were saying that Mona doesn't. I'm like, we still do Mona. Mona still works all the time. So you have a patient, Onam, it's the same. Okay, that's fine. It's the same Mona. Onam, Mona. It's the same thing. O for oxygen, N for nitroglycerin, A for aspirin, M for morphine. So we were taught Mona 12 lead EKG. So what is missing from your management here? So you have the patient that already is getting a little fluid. You already gave the aspirin. You already gave the nitroglycerin. You already put on the oxygen. Nice. Yeah. So I meant the order changed. They told me no, but maybe I'm wrong. Okay. So you go ahead and do your morphine. So the next thing is that you'll get your morphine. So if you already gave your nitroglycerin, it's not working, meaning it's not causing that vasodilation to, you know, cause a patient to have more oxygen going to, or blood flow to the myocardium and increase the oxygen and prevent that ischemia or worsen ischemia that is going on, then you can go ahead and give your morphine to help with the pain. All right. Are they going in shock? We're not so sure if they're in shock. They're getting their fluids and their blood pressure is fine. So we're not going to be doing the vasopressin. I wanted you guys to talk about because I'm saying you've already given the 3 nitroglycerin. After you give the 3 nitroglycerin, we're not going to just put the patient on a bed or on a stretcher and send them over to cath lab. There are other things that we can do in the meantime. So that's the part I want us to go through. So we already have, you know, the fluids going. You gave 3 nitroglycerin. So what is next in terms of pain management? Because this patient is having pain. You're going to want to address the pain. So go ahead and get your morphine. More than likely that is order. I will send them to cath lab for you because I don't know what to do. So go ahead, if you've given them the 3 nitroglycerin, they're not responding, go ahead and give your morphine, and then from there. In terms of the order that you guys said that the ONAM, if there is a problem with, you know, some person said that the oxygen, they're saying that the oxygen is not something that you give. Again, I just know that if you're having chest pain, because of the ischemia that is going on, that's how you're having the pain. So you give the oxygen to help with perfusing. But some persons are saying that if the oxygen saturation is good, you don't need to do your oxygen. In my, you know, I just think that if they're still having pain, then you have worsening ischemia going on. So it's not going to hurt giving them the oxygen. But it's up to you guys. And then you'll go ahead with your aspirin. You definitely want to get your aspirin on board as soon as possible. Get them to chew that up. And how I do it is if I have the patient and I have the medications, you know, side by side. I have the nitroglycerin and I have the nitroglycerin and I have the aspirin. I go ahead and try to get the aspirin going. You know, because it's going to take you a few seconds to throw up the aspirin if I can get the aspirin going. If not, because by the time you put the nitroglycerin under, you know, it's going to be there for a little bit. So it depends. It's OANM. Okay. So I try to get that going, the aspirin going, let them chew it up. Then I put the nitroglycerin under. It's going to be there for a little bit. And then from there, you know, your morphine. So just think about what is happening and then from there, do your thing. Is it cath lab after the ONAM? So it depends on what is going on. Not all the time the patients end up going to cath lab. Is there standing orders in the ER for all this, or do you have to wait for the doctor to order? So there are standing orders in the emergency room for, you know, a lot of things. Your sepsis, your chest pain, GI, abdominal pain, you know, there's like a ton of standing orders. But as you go along, you will know what to do under certain situations if the doctor is not there. Yes, it's like bundles, JPP, joint practice protocol. So some facilities do have it, some don't. When it comes down to chest pain, it's the same thing. Some facilities had nitroglycerin as a part of it, but some persons were, you know, that's why I say you have to just think of what is going on. Look at age. Look at what is happening with the patient, because some facilities had nitroglycerin as a part of their joint practice protocol or the bundles. And so, for example, a 13-year-old comes in and they say that they're having chest pain. Guess who is getting nitroglycerin? The 13-year-old is getting nitroglycerin, because some of us are not understanding and thinking that, yes, you can have a 13-year-old having chest pain, but it might not be cardiac. It's highly unlikely that it is cardiac, especially when you get a history and you hear that they don't have any underlying problem. So you have some facilities that took away the aspirin from them. Yeah, and it's not the aspirin, the aspirin as well as the nitroglycerin. So you can get your EKG, but don't go ahead and throw nitroglycerin at everybody just because probably your facility says that chest painers get. Just make sure that you think about what's happening. Look at the age, look at the condition, you know, the patients have, and then from there you make that decision if you want to go ahead and do your nitroglycerin. And you talk with your senior nurses and your providers as well. But don't let it be a case where you're throwing out aspirin and nitroglycerin to everybody that comes in and says that they're having chest pain. All right, so the orders are there for you to do basic things in the meantime, because sometimes the doctor might be over another room trying to do a CPR and you're there. What can you do? You run and you get your EKG in the meantime. You realize that this patient has a heart problem. The patient is hypertensive, you know, or the patient is an 80-odd-year-old. They talk about, you know, having chest pain or back pain. And you be like, okay, then this patient is having, like, you know, signs and symptoms of MI. Let me go ahead and get this done in the meantime. And you do your thing. You let your provider know. Nobody's going to be like, oh, you did, you know, give your aspirin to the patient that is suspecting to have MI. No, they're not going to be like that. But once the orders are there, you just go with it. But when it comes on to your nitroglycerin, just be careful who you give it to. Get your EKGs, have your providers look at it, and then from there, they will make the decision. Go ahead with your nitro. Can be stress that cause the pain. Exactly, positive vibes. The other thing is when it comes on to your sepsis, some facilities have your sepsis that you have to, you know, you have to call your code sepsis, which is fine. But you have some individuals, just because they're flagged in their vital signs, you call sepsis on everybody. And I keep on talking about it because sometimes you have sepsis call on a person that is rushing from their car into the hospital, you know, and you hear that, oh, the heart rate is elevated, the person's, you know, respiratory rate is elevated, the blood pressure is elevated, the sun hot outside, but now you realize the temperature, the person have a fever, and you call a sepsis on somebody who doesn't have any other indication for, like, you know, a true sepsis workup, and you spend $1 million, or, you know, you spend your entire day doing that workup only to find out that everything comes back normal for the patient. Just make sure you look at what is happening, understand why you need to do, like, your, you know, your aspirin, your nitroglycerin, when to do your sepsis workup and all. My cousin passed from sepsis. It's no joke. I'm sorry, Brit. Yes, it's no joke when it comes on to sepsis. Same with high blood pressure. They have preeclampsia. They just run into the hospital and anxious. Exactly. So, all right. I don't know if probably you guys would know this one, but a new onset atrial fibrillation with RVR. The nurse gives IV beta blocker without checking heart failure history. That's the error there. What's the error? So you have a patient that has a new onset atrial fibrillation with RVR, and then the nurse gives IV beta blocker without checking heart failure history. Enrique says bad. Sarah says bleeding, hemorrhage. Okay. So giving the AV nodal blocker without assessing heart failure, that is a problem. So assess for decompensated heart failure and choose the rate control appropriately. Some agents contraindicated in acute decompensated heart failure. All right, so this beta blocker here, this beta blocker and heart failure is a problem. All right, the patient already have low output, so you're gonna give something that is gonna block, is gonna further worsen that patient's heart heart failure. You have a patient that is post-PCI, receiving full dose of anticoagulant therapy plus thrombolytic inadvertently. Yes, they need anticoagulant. They do need anticoagulant. But the question was about a beta blocker. So this patient here is a post-PCI patient. What is PCI? When you see PCI, what is that? If somebody says that this patient is 5 days post-PCI, what is PCI? So they're high risk for bleeding, yes. High risk for bleeding. They don't need thrombolytic if PCI. Catheterization. Percutaneous coronary intervention. So the patient is on full dose of anticoagulant plus thrombolytic inadvertently. Two of those medications are, high risk for bleeding. This patient just had PCI. So anything that has to do with like stent placement, who was it again? Like Bedside. Like persons who like have stent placement, those tends to help with keeping the artery open. So you give that patient both of those. The patient is going to be at risk for bleeding. So you don't want to go ahead and duplicate. So always just go ahead and verify the dose. Which of them they want to keep, discontinue, go ahead and do that. So verify the order and reconcile the medications before administration. Withhold extra agent until confirmed. So you want to avoid any form of bleeding, major bleeding for this patient. Exactly, that's what, exactly. So make sure you don't have the patient on both of them. Yes, mainly DIC. Let's just say I want to make it as an ER nurse. Eventually, you will get it bite-size. You will get it. You will get it eventually. And our Plavix 75 or Brilinta BID. Thank you, Ashley. After PCI, patients are placed on dual antiplatelets. Yeah, but the problem here is that this one is like, patient is on like full dose of anticoagulant and the thrombolytic here. So Plavix is fine with them. All right. Protamine and vitamin K. CP, yes. We're going to need protamine, vitamin K. Lord help me when I start it. You're going to be fine. Nothing surprises me. Nothing surprises me. You will be fine, okay? Uh-oh. All right. I don't think you guys see it. So protamine is the antidote for your heparin. Yes, bite-size. So a chest tube is placed and the nurse clamps it routinely to prevent air entry. So you have a patient that has a chest tube and the nurse clamps it routinely to prevent air entry. What is the problem here with this? What is the problem here? Keyword is routinely. So no, never clamp. You see kinks and dislodge. Never clamp. So clamping the chest tube is unnecessary. So you want to go ahead and keep the chest tube unclamped unless specifically ordered. Monitor your drainage. The nurse continuously clamping. What is that patient at risk for? So fluid and air buildup back in the lungs. Okay, yes, Rose. So the patient is having this tube clamping frequently. What is this patient at risk for? Just think about it. You have a patient that has a chest tube. Why do you put in a chest tube? You have a patient that has a chest tube in. Okay, CP says pneumothorax. Cashley, welcome. Attention, pneumothorax. Yeah. So if you're constantly be blocking off, you clamping off the chest tube, you can have all of that tension building up. All right. So you have the tension pneumothorax that can result from that. A patient with suspected STEMI is left unrushed while awaiting echocardiogram. So we definitely need to do that ultrasound of the heart. We need to see what's going on. So the patient is suspected to have a STEMI. What is STEMI? What is STEMI? Heart muscle will die. Yes. What is STEMI? Full occlusion, ST elevation, needs to be rushed. Yes. Run. Where do you see STEMI? In the blood or on the EKG? On the EKG, yes. And what? Okay. And what test do we check? What test do we check to look for that enzyme? What test do we check to look for that enzyme? Troponin. So you do your troponin for your So what about the CK? What about why not like a CKMB? Why would you choose a troponin over a CKMB? Why would you do the troponin and not a CKMB? Because isn't the muscle just the same? Why wouldn't you do the CKMB? Troponin will show tissue death. Not elevated immediately. Okay. Troponin is more specific. It is more specific for your cardiac muscle. Creatinine kinase maybe takes longest to show. Yes, so it's more specific for your cardiac muscle. It shows a longer time tissue damage. Exactly. So the patient is suspected of having STEMI, is left unrushed while awaiting echocardiogram. So that is a problem there. Delaying reperfusion evaluation. So you activate your STEMI pathway, PCI for or thrombolysis pathway immediately per protocol. We say time is muscle, door to balloon, timelines matter. So the tissue, time is muscle. Yes. Okay. Cath lab. Bite size love cath lab, you see? Bite size love the cath lab. The nurse gives TPA without confirming CT head in stroke patient mimicking MI patient. So you have a patient that is, has done a CT scan, but the nurse went ahead and gave a TPA without confirming. What is the problem? It's kind of like ER love sending all pregnant people to LND because they're pregnant. Hey Val, welcome. So CP says bleeding. Yes, so the nurse gives TPA without confirming the CT head in the stroke, mimicking MI. So risk for bleeding. What are some contraindications for giving TPA? What are some contraindications for giving TPA? What are some contraindications for giving your TPA? Recent fall, recent CVA, brain bleed. So Mochi, recent surgery, high blood pressure has to be given in the 3 to 4.5 hours of symptom onset. So for the recent fall, so if I fell yesterday on my bum, you know, I'm okay. Am I contraindicated to getting TPA, you're saying, Mochi? I fell 2 days ago, you know, fell on my back. Am I contraindicated to getting TPA? No. So unless you fell and you hit your head, then I'm thinking, yes, Cashley, if you've had a fall and you hit your head and you had trauma, then that would be a contraindication. Just be a little bit more specific as to, because TPA isn't a massive blood thinner. Brittany, what is TPA though? What is TPA? Are you asking a question? Yes, TPA is a massive blood thinner. You don't play around with TPA. All right, let's go again. What is TPA? What TPA stands for? Because we're treating with TPA, but we probably don't know what TPA is. Thank you. Yes, tissue plasminogen activator, plasminogen altiplase, thrombotic. So tissue plasminogen activator. Nice. Before you give you go ahead with this patient. So you have a patient that is having symptoms that is mimicking a stroke. What is very important for you to get for this patient? So you have a patient that comes in and you're going to get this patient over to the CT scanner. What is very, very important for you to get as a part of, we're going to say as a part of vital signs, or one of the first things that you need to do prior to getting that patient over to CT, or while you're running over to CT, you're trying to get that going. Blood sugar. Okay, nice. JB, why would you want to get the blood sugar? The patient not diabetic. Why you want to get the blood sugar? Why you want to get the blood sugar? So this patient, what's the answer? Was it blood sugar? I'm asking JB why you want to get a blood sugar for this patient, JB, or anybody else. I think I saw who else says blood sugar. Positive vibes. Why you want to get a blood sugar on this patient? So this patient has the symptoms of a stroke and you're going over to CT scan. Why you want to get the blood glucose for this patient? It's very, very important to check to see if you're hypoglycemic. Yes, it says mimicking, so could be hypoglycemia. Yes, so you go ahead and get your glucose to make sure you're not sending a patient who needs a little bit of a glucose, dextrose water to correct their stroke-like symptoms. Not saying that they won't do like a CT scan. Some providers will still go ahead depending on the additional symptoms that the patient is having. But you want to get that, so if in the event that the patient is hypoglycemic, you can still correct that because the brain needs the glucose. So either way, you need to fix the glucose first. So what's the difference between TPA and TNK? What is the difference between TNK and TPA? So we know both of them are what? Two clot busters. What's the difference between the two of them? And what is TNK? Technoplace? Let me see. All right, so I'm looking it up. Yeah, it's Technoplace. I know a lot of times we use the TPA. Difference between TNK and TPA. So I'm not 100% familiar with the Technoplace. So both of them are thrombolytics, as we say, used to dissolve clots, but they are not the same. TNK is a single dose given at once, faster, easier in emergencies. Okay, so in the rural areas and in ambulance, then that is what is, most of the time given, the Technoplace. And then TPA, which is the Altiplace, is the one that is weight-based. So this one, you have to get your weight on your patient. You have to get the actual weight. Then you do it over a time period. So you give the bolus, you do the 90 minutes, and then the 3-hour infusion. So this requires the pump, monitoring on the pump and close, requires the pump and close monitoring. So yeah. TPA has slightly higher bleeding risk than the TNK. All right, so that's just it. So in the hospital, you will see them use the Altiplace a lot. If you're in the rural area, then or on the ambulance, you probably see the TNK based on what they're saying, because it's a one-time dose and it's faster and easier. I knew both are used for strokes. Okay, CP. I know both of them are like clot busters, but the one that I'm familiar with is the TPA. So I had to look up that one, the TNK. Okay, so the answer here, the nurse gives TPA without confirming the CT head in stroke mimicking patient, MI patient. The problem is that she didn't verify contraindications before thrombolysis. So how you go about with fixing is to confirm the contraindications, and we already listed them, and the necessary imaging and labs prior to TPA. So if you see a bleed on the CT scan, definitely you cannot go ahead with your TPA. The rational thrombolytics carry high bleeding risk, so you want to ensure that you check. All right. The patient on digoxin with nausea, the nurse dismisses it as gastritis and doesn't check the heart rate. Nausea, everybody have nausea. What is so special about this case? Like, is there anything wrong with this case here? What is happening with this patient? Like, a lot of people have nausea. So, yeah, what is so special about this patient? The patient is on digoxin with a little nausea, just a little nausea. The nurse dismisses it and say, oh, it's gastritis, ma'am, and doesn't check the heart rate. Okay, why are you thinking digoxin? Is it because of you just see the digoxin on the board and the heart rate and just say, oh, it's, it's digoxin toxicity? Yeah, but why are you saying it's digoxin toxicity? Check peak and trough for, okay. Yeah, but why you think it's digoxin toxicity? Is it because we've been doing a lot of questions with digoxin, checking the heart rate, and we just say, oh yeah, this patient is. But what in the scenario here is saying that this patient is possibly toxic from the digoxin? What is the giveaway? The GI symptoms. Thank you, Delcia. Thank you. So I don't see anything in the situation, the scenario with the low blood pressure by its size. So So this patient, the giveaway here is the fact that this patient is on digoxin and the patient is having GI symptoms. This patient is nauseous. So that's how you're gonna come about with, you know, oh, this patient is toxic from the digoxin. So what can you do for this patient? What can you do for this patient? So you recognize that this patient is overdose on digoxin. What will you be doing for this patient? Why does it cause nausea? I really don't know. It's just a side effect. What will you do for this patient? You will stop the medication. John says give naloxone. Who are we giving naloxone here for? What's the antidote for digoxin overdose? Is it naloxone or Zofran? I see there. I know the Zofran is for the nausea. Or is it Digifab? So yes, Bedside. So John, naloxone is for your opioids. You want to give your Digivine, Digifab for your digoxin overdose. All right. So naloxone. Yes, John. So, and then the nurse needs to also check your heart rate. So the heart rate. Ask if they're having trouble with vision. Yes. Naloxone is for opioid. Is John the psych nurse? John, are you the psych nurse that came on the live the other day? I don't think it was you. Okay. So in terms of the vital signs that you're checking, so the heart rate, at what rate are you looking for in order to give this medication? Oh, you're just a student? Okay. What heart rate are you looking for that is acceptable to give a digoxin? Anything above? So yes, anything over 60. Anything that is over 60, you want to go ahead and administer your digoxin. If it is below 60, you will go ahead and hold the medication. So the problem is that the nurse ignored the early signs of digoxin toxicity, which is the nausea here in this scenario. And you want to go ahead and check the apical pulse, get your EKG, your drug levels, notify the provider. And then from there, you know, continue with your management. So early detection prevents arrhythmias in these patients. You have an hypertensive emergency, the blood pressure, apical pulse for 1 minute. Yes, you do the pulse for 1 minute. Which other, who else do we do a pulse check for 1 minute? 1 full minute for? Who else do we do pulse check for 1 whole minute? When do we do the full pulse check for 1 minute? Babies, bite size, thank you. Yes, so for your pediatrics, your babies, go ahead, get your 1 whole full minute for your pulse check. And what else? Metoprolol. Okay, yes. Go ahead and get your full minute. So I have a patient here that is having an hypertensive emergency. Someone with AFib. Yeah, you can get your, if their rates are irregular rhythms, you know, definitely you want to go ahead and do your 1 whole full minute of your apical pulse check. Because just imagine if it's irregular, you can't really say you're going to check for the first 15 seconds and then multiply it because the rate it's irregular. The beat is irregular. So you still have to just go ahead and do your entire 1 minute of pulse check. You have a hypertensive emergency here. Blood pressure is 220 over 120. The nurse gives rapid IV push antihypertensive to normalize the blood pressure quickly. So the hypertensive emergency here, 220 over 120. The nurse gives rapid IV push antihypertensive to normalize BP quickly. It's probably supposed to be slower bite size. Okay, it can cause rebound hypotension. So this rapid rebound tachycardia, you don't want to go too fast with the IV push. You don't want to drop their blood pressure too fast, because that can cause worsening in terms of like with ischemia. Can cause like they give the fluids. A drop can cause them to have ischemia. So if you drop it too fast, that's a problem. So lowering the blood pressure. So rapid aggressive blood pressure reduction is a problem here. You don't want to drop your blood pressure from 220 to 110/60 in like 15 minutes. No, you don't want that. Take your time and slowly titrate your medications and drop that blood pressure safely. So lower the blood pressure gradually using titratable IV infusion per protocol, because you don't want to cause, ischemia because of that rapid drop. Always push slowly. Yes, positive vibes. Lower 25% for the first hour. Yes. And then eventually, especially with which patients? Well, which patients? So you have hypertensive emergency patients here. Which other patients do we normally do that titration for the blood pressure? Slowly drop the blood pressure in. Who else? The old people. Hypertensive emergency patients, yes. Pregnancy. Wasn't really thinking about the pregnancy for any patient, but there's one specific one that I'm thinking that we would be, saying. It's still in the same hypertensive emergency kind of class there, in a sense. Still having to do with blood pressure, heart. I was thinking of your stroke patient. Hi, Erin. I see you. How are you doing? No, not your nitro drip. Yeah, but your stroke patient as well. That's what I was looking for, just because we're talking about hypertensive emergencies. So you have to slowly titrate, the medication, drop their blood pressure. You don't want to drop it too fast for them because of that ischemia. Okay, Eiley. Okay. Not a problem, Mochi. Oh, we had one similar to this one, but a little bit different in terms of the wording. The patient with chest pain and suspected MI placed NPO, but not given chewable aspirin. So you have a patient, because these are scenarios that happens every day. You have a patient with chest pain and suspected MI, placed NPO, but not given chewable aspirin. So what's the problem here for this patient or for this nurse? What did this nurse do? What's the error? They can usually take SIPs, yes. Take meds, NPO, yeah, with small amount of water. So the need stent placement could be STEMI. Okay, G.24. But we're trying to spot the error in the scenario here. So we're trying to spot the error, and then we'll try to fix it. So this patient is with chest pain and suspected to have a MI. The patient is placed NPO, nothing by mouth, but not given the chewable aspirin. Why NPO? You tell me, bite size. Why is this patient NPO? Why is this patient NPO, bite size? The nurse should never hold aspirin. Thank you. Positive vibes. Shouldn't hold prophylactic. Give sublingual nitro. We're not talking about the nitro here. So the patient is chest pain and the patient is suspected of an MI, is placed NPO, but not given chewable aspirin. Exactly. So you NPO the patient because of possible surgery, cath lab, maybe heartburn. John, no. So the patient is a chest pain, suspecting to have MI. You're thinking that probably this patient is gonna go, to cath lab. But the patient is NPO. You don't want to feed this patient because the patient is gonna go do a procedure. So you don't want to feed the patient, but the patient has aspirin that is needed, well needed. So the patient needs the aspirin, and we already established why the patient need the aspirin. Why is the aspirin very, very important in your ACS protocol as well as your MI patient? Why is it very, very important? Why you want to get that aspirin on board? Antiplatelet cordelia. Yes, it prevents that clumping we said earlier, the clumping, the aggregation of the platelet. So it prevents further clotting. So you want the aspirin on board. So even though the patient is NPO, still go ahead and give that little aspirin. We said 172 to 324 to 325. Go ahead and give your aspirin as per order with small amount of water. We're not going to give any big cup of, soda or... No, we're not doing that. Just a small sip of water, crush it, and you give it to the patient because of, they're at risk for, in terms of with the mortality rate as it relates to MI, you delaying that medication can cause further problem for the patient. So even if it is NPO, sips of water with meds is okay. Exactly. Yes, ask for NPO except for meds. It will be, it will be, the order is going to be there. The order is going to be there. NPO doesn't mean hold meds. Exactly. You just don't need to take it with an entire Stanley cup of water. No. Small sips and that's it. Just wet the mouth, swallow it. And that's it. So the chest pain suspected of MI, placed NPO but not given chewable aspirin. The nurse should have given the chewable aspirin, and that would have been the problem. So omitting the immediate aspirin is a problem here. So you give chewable aspirin unless allergy exists. Early antiplatelet therapy lowers mortality risk. Post cabbage. What is cabbage? And don't tell me the one we eat. What is cabbage? What is cabbage? We hear it every day. We hear it every day. What is cabbage? Complete heart block surgery thing. Bite size. Coronary artery bypass graft. Thank you, John. Yes. Fran, welcome, welcome. Danix, welcome. Jenny, Jet. Oh, remember, guys, go ahead and tap up the live. And remember to go ahead and follow the page here. Yes, so coronary artery bypass graft. So yeah, when I ask you to say it out, it's because sometimes you might see it and you don't remember exactly what it is. And so I just want you guys to get into the habit of remembering what TPA is, what, cabbage is. So don't mind me when I ask you what it is. So yes, the coronary artery bypass graft. Hi, Arlene, how are you doing? So you have a post-op cabbage patient pulling at pacing wires. The nurse went ahead and cut the wires to remove them. Less problem. What is the problem here with this? That nurse is smart. Oh, gosh. So, the nurse cuts the wire to remove them. We ain't doing any cutting. Okay? The pacing wires, pulling at the pacing wires. Not smart at all. So... even though we have a trauma scissors, we don't use our trauma scissors to go do any form of cutting of any pacing wires. So removing the epicardial pacing wires without the provider order. So secure the wires and notify the surgeon for safe removal per protocol. Improper removal can cause bleeding, tamponade, and loss of your nursing license. It's like that nurse who cut off the patient's foot when it was dangling. Can't manage. Yes, so do not do any form of cutting, okay? We ain't cutting no pacing wires. Most of these nurses lose their license tonight. Exactly. All of them. Never do anything without an order. But even if an order is there, are you gonna go cutting that pacing wire as G24? We're not going to cut any order. We're not gonna cut that pacing wire. I'm gonna tell the doctor to come and cut it. I know me put it in. No, sir. I know me put in the wire there. So whoever put it in can come and cut it out of my scope. So I will bandage it down, tape it down, keep it from dangling. But yeah, even if there's an order, you can question it exactly by its size. So not because it's there, it doesn't mean that you rush and do it. And that's the thing. A lot of times we are scared to ask questions because I know that, yes, the doctors, yeah. And so we feel as though we can't ask any question. If you don't want to ask the doctor any question, find somebody, you know, and talk with them. Go to your you know, other nurses on the floor and hear what their opinion is. If you're not comfortable with it, call your boss, call your charge nurse and say, hey, you know, the doctor down here asking me to come and cut this spacing wire. You know, just do that. So that's just it. They make mistake to ask charge nurse. Exactly. So don't do that. You have a patient with a new S3. What is a S3? We're not talking Samsung here. Because I think we're at what? Samsung 21, S21. So what is the new what is S3? What is new S3 or S3? What we know about heart sounds? Murmur, gallop, yes. Third heart sound, Nursing care continues, welcome. So it's a heart sound. Heart failure possibly, Jasmine. The girl them fave, walk one. Okay, so the third heart sound, who is it usually okay to have a third heart sound? It's like a normal heart sound for some persons. Who is it okay? If you hear a third heart sound, who is it okay to say, okay then, yeah, you're good to go? But yeah, so for the babies early, couple of days, it's okay. But for who else? You hear it for your heart failure patients, pulmonary edema patients. What if you hear it in like somebody that is like a younger adult, athletic, you know, somebody who is always out and about running in the gym? You have those athletes out there and you hear the heart sound. That person is probably like in the late 20s, 30s. Would you be concerned about a S3 heart sound in those young folks? So your S3 heart sound, would you be concerned about your S3 heart sounds in your young adults? Danik says yes. Peg for real says yes. Okay. So Bedside says no. All right, nice. So let me just pull up something here. So S3 sound is abnormal. It is a classic sign of heart failure, specifically left-sided heart failure, dilated cardiomyopathy, fluid overload, mitral regurgitation, high cardiac output states such as pregnancy, anemia, and thyroid storm. So if you hear a S3 in an adult, think about heart failure. The next thing is it can be normal for your children, your young adults, anybody that is less than 35 years old who has S3, it can be normal for them, and sometimes in pregnancy. In these groups, which is the children, the young adults that is less than 35, and the pregnant mothers, in these groups, S3 is due to a stronger, healthier ventricle normal variant. So that's what I'm saying. If the person is like a young adult, you know, you have some persons who are like bradycardic, and it's normal for them. You have your athletes, it's the same thing with these folks. They will tend to have like a S3 heart sound, and it's okay for them. Why does a S3 occur? Rapid filling of the ventricle leads to too much fluid and the ventricles becoming weak. Then you have the ventricles vibrating, leading to S3 heart zone. So this is why you have your patients having the congestive heart failure. Okie dokie. So it depends on the age group. It depends on the age group for your S3. So the patient with a new S3 and worsening edema, given IV fluids per standing order. So you have the standing order there, and the patient has a new S3 heart zone, worsening edema, but yet still you go ahead and give IV fluids per standing order. So you have, you know, the doctor put up the order and say, yeah, if the patient needs fluid, you go ahead and do this. But you assess the patient, or this nurse assess the patient, and notice that the patient has the S3 and the patient also has worsening edema. So she said, you know that the blood pressure is low. Let me just go ahead and give the fluids. Hang it. What is the problem here? Yes, you want to stop the IV, no fluid, because we already know that S3s, you know, for your patients who are having heart failure, and the fact that this patient is having this fluid shift, the edema, then you don't want to go ahead and do any more fluid. You're just going to overload this patient. So the problem is giving fluids to a volume overloaded heart failure patient. Hold the fluids, administer diuretics. What class of diuretics would you give this patient? What class? So no fluids since the patient has edema. Exactly. So what class of diuretics would you give this patient? Loop diuretic, furosemide. All right. So Jenny is asking osmotic. What is an example of osmotic diuretics? Or Jenny, so mannitol. Where does mannitol osmotic diuretics work? What's the pathophysiology behind your or the mechanism of action with your osmotic diuretic? You use it for ICP, use it in the brain, it works in the brain, cranial, yes. So osmosis. Increase it, yes, it's used for increased intracranial pressure. Exactly. So for this patient, the one that would be best would have been your loop diuretics. The osmotic is gonna be for like your ICP. Anything related to the brain is gonna be pretty good with that medication. So you hold the fluids. Okay. Yeah, so you hold the fluids, administer your diuretics, notify the provider. We know that fluids worsen pulmonary edema, so you want to just hold off on that. Okay, so you're administering your antidiuretics here to this patient. We say we're going to give a loop diuretic, and let me see how many persons give an example. John says furosemide. What are you going to be having this patient at risk for when you give them that loop diuretic? So this patient is so overloaded, you're giving 60 or 80 milligrams of furosemide twice daily, once daily. What is this patient at risk for? Hypokalemia. Nice. So it wastes many electrolytes. Hypokalemia. Good. Just watch out for hypokalemia. Check potassium and check creatinine. Positive vibes, yes. You have a patient here in cardiac arrest. The team leader delays defibrillator arrival because someone else is doing compressions. So they're like, oh yeah, we don't need to do that. You're doing very, very high and, you know, effective chest compression. So we won't disturb you. What is the problem here? The patient in cardiac arrest, the team leader delays defibrillator arrival because someone else is doing compression. So then it could affect heart rhythm with hypokalemia. Yes, it's going to cause problems with your heart rhythm. So you want to ensure that you are monitoring. You keep that patient on the cardiac monitor. So I know a lot of times, you know, we have patients in the hospital and you're saying, oh, why you need to put that patient on the monitor? Yeah, because you're eventually going to give your CHF as your diuretics. So you definitely need to get them on there to see the changes. So the patient in cardiac arrest, the team leader delays defibrillator arrival because someone is doing compressions. What's the importance of this? What is, defib, you need to restart the heart. Brittany, yes, do not delay. It should be given or done first. Yeah, because this is what, like electrical activity. You're gonna, restart. You're gonna shock. You need to shock the rhythm. Exactly. So even if someone else is doing the chest compression, getting that electrical activity, get that shock going is very, very important. So the patient in cardiac arrest, team leader delays defibrillator arrival because someone else is doing the compression. Do not delay any shockable rhythm. Prioritize early defibrillation for your VT and VF while maintaining CPR. What is VT? What is VT and VF? What is VT? Place the pads while doing compression. What is VT? Ventricular. VT, Brittany. Okay, ventricular tachycardia. Ventricular. Oh, and VFib. Okay, sorry, Brittany. So yes, are those shockable rhythms? Are those shockable rhythms? Are those rhythms we can sit and, be TikToking away on our phone looking at because the rhythm looks so good? Are those shockable rhythms, or, we can be like, yeah, we need we need to get those shocks going. So yes, they're shockable rhythms. So early shock increases survival for your patient here. Let's go on to, well, this one. I know this one is a little bit, but you guys are supposed to know adenosine, right? Yeah, we're learning tonight. The patient with stable SVT. What is SVT? What is SVT? Adenosine restarts the heart. What is SVT? Supraventricular tachycardia. Okay. So you have a patient with stable SVT getting adenosine, but via a slow running IV line in the wrist. What is the problem here? Yes, Jonathan, the problem here is slow. This is a problem. The slow running, no, we don't do the slow running thing with this adenosine. Okay. So you need to do you need to push fast with it and get that flush going after. So usually you do the stopcock. The two nurses will do it. So you'll have one doing the adenosine or the flush, or the provider, whichever one. So you'll have two persons doing it. So as soon as you get that adenosine, you get that flush in. So it's a two-man thing. So if anybody, well, it says stable. But if anybody asks you to go ahead and do it, no. Get somebody else and both of you go ahead and do your adenosine. Because the last thing you want is to look on the monitor and you see the patient very, very flat line, on the monitor. And you don't know what else to do. So you're going to see, and you just make sure that everybody is there ready in the event that that flat line doesn't go back to a sinus rhythm or a rhythm that is, yes, it is very scary. It is very scary. So make sure you have somebody else there doing your adenosine with you, and from there, okay, get your crash cart, get your patient on the cardiac monitor. You have your defibrillator ready, and everybody in the room is ready to give that adenosine. So it's not no slow running, nothing. All right. So giving adenosine via slow or distal IV is a problem. So give adenosine as a rapid IV push through a large proximal line followed by a flush. Rapid administration is needed for the effect. And sometimes as soon as you push it, you can literally look on the monitor and just see things just happening. Okie dokie. All right. What time is it? 9 o'clock? All right, I'm gonna do one case study with you. I think it has about 6 questions, and then I'm gonna go to my bed. Yeah, I've worked tomorrow because I never work Monday and Tuesday. It's Monday and Tuesday? Or Tuesday and Wednesday? Yeah, I work Tuesday and Wednesday, so my patients are gonna be, I'll see my patients. I saw my patients today and we'll be seeing them tomorrow. Yeah. So I have 6 more questions. Is that too small, or let me see? Oh, readable. Still readable, right? Yeah, it's still readable. Thank you for joining in. All right, good night, positive vibes. Is it too small? All right, let me put my little paper up because I don't want you guys to see the answer. So I'm going to put my paper up and adjust the font on it. Let me just adjust the font. So at least and then we'll just do these. Okay. I just hope it doesn't affect the. Okay. Gracias. Ilinia, welcome, welcome, welcome. All right, so you have a scenario here. A 62-year-old male is admitted from home with fever, confusion, and low urine output. His wife says he's been sick for 3 days with chills and diarrhea. He has a history of hypertension, diabetes type 2, CK or chronic kidney disease stage 3. So 62-year-old male, fever, confused, low urine output. What are we thinking? He's been sick for 3 days, chills and diarrhea. He has hypertension, diabetes 2, and CKD stage 3. Guy that makes football, hi, welcome. How are you doing? The temperature, as we say, 103.2, heart rate 128, so it's tachycardic at 128, temperature is 103.2, blood pressure is low, 86/52, respiratory rate is 28, SpO2 is 90%. Based on this, what are you thinking is happening with this patient? Based on just the vital signs here. Sepsis, fashion Clarice, welcome. Sepsis, tripped, metal detector, yes. John, so based on that, we find out that this patient is having sepsis. This patient is heading into septic shock. Pat Alves says C. diff, because the patient is also having diarrhea, sick for 3 days, okay. All right, so let's go on. The patient is confused, disoriented, cool, mottled extremities. The capillary refill is greater than 4 seconds. So capillary refill is greater than 4, dry mucous membrane, and the urine output is 15 mils per hour. It is dark and concentrated. So this patient is dry. All right, we look at the labs and we realize that the white blood cell count is 22,000. Bacteria, lactate is super high, 5.4. Sodium is low, 132. Potassium 5.6, BUN 58. Creatinine is 3.1. Glucose 236. A bunch of things going on here. pH is 7.3. PaCO2 is 30 and a bicarb of 18. What acid-base imbalance is this patient in? What acid-base imbalance is this patient in? hyperpotassium. Okay. Metabolic acidosis. Okay. So this patient is acidotic, metabolic acidosis. Do we have any compensation going on? Do we have any compensation going? Jenny says partially compensated. What is the normal value for your PaCO2? What is the normal PaCO2? What is the norm for your PaCO2? 3245, okay. 22 to 26 for your bicarb and your pH 7.3. So is this patient compensating? So metabolic acidosis, partially compensated. Why you say uncompensated, Jasmine? So why would you say uncompensated? Or Joe Mamo? It has to be partially since neither of the two pairs not in there. Exactly, Jenny. So I wanted to find out. So Jasmine. So that's what I was asking. What is your normal value for your PaCO2? So even if it is close to normal, it's not normal. So if it's not normal, it is gonna be partial compensation. So even if it is 1 point under, it is still compensating. It's just not fully compensating. So PaCO2 is 35 to 45. So close to normal in the real world, close to normal is, you know, sometimes we say normal in terms of with your lab values. But when it comes on to NCLEX world and when it comes on to your ABG, you have to be very, very careful with those. Okay. So we realize that this patient is in sepsis there. So which finding indicates that the patient is in septic shock? Select all that applies. So you have A, hypotension, elevated lactate, confusion, hypothermia, warm flush skin, and tachycardia. So which finding indicates that the patient is in septic shock? Which finding indicates that the patient is in septic shock? A, hypotension, B, elevated lactate, C, confusion, D, hypothermia, E, warm flush skin, or F, tachycardia. Stella says ADF, Brittany says F, A, B, C, E, F, John says, okay. CEF, which is confusion, warm flush skin, tachycardia, ADE. Wait, we can pick more than one. I changed my answer. Yes, Brittany, they give you 6 options there. So try and find at least 2 to 3 out of it. Okay? Not D since the patient has fever. Okay. So whoever it said A, B, C, F. So let's go up here. So septic shock, you have the hypotension, the high lactate, greater than 4. The patient is altered. And you have tachycardia. So hypotension, elevated lactate, confusion. Warm flu skin is early sepsis, not shock. Hypothermia may not, but is not as specific in this context. So, which finding indicates that the client is in shock, in septic shock? So, hypotension, the elevated lactates, your confusion, and your tachycardia. Hypothermia, because this patient is having a fever. Warm flu skin, those are the ones that are not indicative of the septic shock. All of them except D. Okay. Jenny. And we know how the hypertension come about in terms of with your septic shock, right? What happens, how the patient becomes hypotensive. What is the pathophysiology behind sepsis? Shock. Why the patient becomes hypotensive? Yes, the massive vasodilation. So because of that massive vasodilation that is going on, you have the patient becoming hypotensive. So A, B, C, F, Candra. And you need to make sure that you get your lactic acid. That's very important. Okay. Gonna do one more question. Oh, I've got to have 6 questions on this one. 6. Okay, so which immediate intervention should the nurse anticipate? Immediate interventions should the nurse anticipate. Select all that apply. A, administer IV fluids. B, start norepinephrine infusion. C, prepare for intubation. D, obtain blood cultures. E, give broad spectrum antibiotics. And F, restrict fluids due to kidney injury. So basically we're using this scenario here. The patient is confused, cool, mottled, capillary refill is greater than 4. The temperature is 103, 128, 86, 52, 28 respiratory rate, and SAT of 90. So based on all of that, which immediate intervention should the nurse anticipate? Administer the fluid, start norepinephrine infusion, prepare to intubate, D, obtain blood cultures, and give broad spectrum antibiotics and restrict fluids due to kidney injury. So A, B, D, E. Okay, so we definitely know we need the fluids. We need fluids. Are we gonna start norepinephrine? They need a lot of fluid due to the vasodilation, yes. So they're hypotensive. We need to correct that. We need to help with that. Starting norepinephrine. Want to give the patient some fluids first, and then if they're not responding to the IV fluids, then we can go ahead with that norepinephrine later on. Prepare to intubate. Put a question mark beside that. Obtain blood cultures, very, very important. Give broad spectrum antibiotics is very important. Restrict fluids due to kidney injury. Are we going to restrict? I'm going to restrict fluids for this patient. No, put a question mark beside that. So who says A, B, D, E is correct? So the fluids first. So you want your fluids first, cultures and antibiotics on board. The most important thing is the fluids. So we need the antibiotics, but the fluids is what we need. Because just think of it, that massive vasodilation that is going on in sepsis, you need to, get that fluid going to help with perfusion. Because it doesn't make sense to go ahead and give antibiotics because yes, the patient is in sepsis, but you don't have you don't have enough volume. The patient is not perfusing well. So make sure you start off with your fluids and then you can go ahead and do everything else. So get your cultures before antibiotics because you want to make sure you get, accurate in terms of with the bacteria. You don't want to introduce the antibiotics and then get the culture because we basically kill it off before it even start growing. So go ahead and get your cultures, your blood cultures from 2 different sites. To get your 2 large bore IVs. Somebody on the left arm, somebody on the right arm. 2 persons can get their blood. You can get it around the same time. It's 2 different sites. You don't have to wait 15, 20, 30 minutes or the entire day before you get your second culture. It's 2 different sites, so it's okay to go ahead and get your 2 blood cultures. If you have 1 line, then you definitely have to wait your 15 minutes before getting your second blood cultures. But if you're having difficulty getting your blood cultures, do not hesitate on going ahead with starting your antibiotics. So you do that. In the meantime, would you get urine on this patient? Would you get any urine on this patient? Would you get any urine on this patient? Would you put in a catheter for this patient? Because that's what I do. When I'm doing, if I have this patient come in front of me, this patient would have already got their 2 IVs. They would have gotten their, indwelling catheter. And I would have sent off their urine before I start any form of antibiotic. So get your urine, send it off, especially because the scenario had said that the patient, there was something regarding urine. Oh, it was just the low urine volume. Okay. But I will definitely go ahead and get a urine sample on this patient. The patient is also a diabetic. Get the urine on the patient and send it off. You don't need an order for it. Wherever there is you can get a sample, get a sample because the patient is having fever. You want to know where exactly the patient is getting that, the source of the infection is. So get your urine sample, send off your stool sample because the patient has been having diarrhea as well. The vasopressor, as I said, the norepinephrine, give it after your fluids if your MAP is still low. What is the MAP you're looking for that is acceptable? Oh, Johnny says it, MAP above 65. So you give your IV fluids and you realize that your MAP is improving. You don't need to be jumping to give norepinephrine or any vasopressor. Just go ahead and push your fluids. And get that MAP up. And once the MAP is above 65, you're good. Acute kidney injury does not mean to restrict fluids during shock. All right, because if you restrict fluids, you're just worsening the shock as well because the kidneys need a little fluid there. It needs some fluid. Intubation is only if the respiratory failure is present. So you don't need to be preparing for intubation. And you're not going to restrict the fluids here. And you're not starting no norepinephrine. You're going to give you a large amount of fluids and then from there, assess your blood pressure throughout. Which finding indicate worsening acute kidney injury? Which finding indicates acute kidney injury? Select all that apply. Potassium of 5.6, urine output less than 30 mils per hour, BUN or creatinine rising, pedal edema, low bicarb, on ABG or a blood glucose of 236. You have 6 answers here. Choose at least 3. And then from there, at least a score. Hopefully you score points for them. So which finding indicates acute kidney injury? We know when you have your kidneys failing, there's a ton of things going on. So always ask yourself, is this a true or false? So we say A, B, C, D. Okay, so look at A, potassium. Just think of your renal patients. Kidneys failing, potassium increasing. Urine output is less than 30 mils. Urine output is less than 30 mils. Yeah, you're going to put that there. BUN, creatinine rising, especially if they put the creatinine rising, definitely, you know, your kidneys. The BUN will tell about your dehydration and all. Pedal edema, is that something that indicates acute injury, kidney injury? No. A low bicarbon ABG, is that something that tells that you're having a kidney injury? So your bicarb here is low. I'm gonna put a question mark beside that one. Blood glucose of 236. I think probably this is just like a distractor here. I don't know. So we say ABC. Okay, so all right. So which finding indicates worsening acute injury? So I see A, B, C, D. Okay, let's go up here. So, okay, so A, potassium, 5.6, urine output, oliguria, creatinine rising. As we said, the B, whoever said D, the pedal edema is not really indicating, you know, acute kidney injury. The low bicarbon ABG rising, metabolic acidosis, okay. And we said that F is like, you know, a distractor for me. So edema is non-specific and the glucose is unrelated. Okay, so hyperkalemia, oliguria, rising BUN or creatinine, and metabolic acidosis. Urine output less than, yes. It's not greater than 30, it's less than 30. So anything, remember you need at least 30 mils or more per hour. All right, so let's move on to number 4. Not a problem, Brittany. So which findings show the client is progressing to MODS, multi-organ dysfunction syndrome? So which finding show the client is progressing towards multi-organ dysfunction syndrome? Select all that apply. A, increasing confusion. And you know, when you hear multi-organ, even if we're not familiar with it, you hear multi-organ, just think about the major organs. Multiple organ dysfunctioning, just think about it. Select all that apply. A, increasing confusion. B, MAP less than 65 despite fluids. C, elevated liver enzymes. D, hyperglycemia. E, respiratory alkalosis. And F, low platelet count. So which finding shows that the client is progressing towards multi-organ dysfunction syndrome? Danik says all. Okay. PAPE, welcome. ABC, increasing confusion. So increasing confusion. So just, yeah, multi-organ dysfunction. So if the patient is not perfusing, well, they're going to have increased confusion. Anything that is below 65 regarding your MAP, because we want your MAP to be greater than 65. So despite getting fluids, this patient's MAP is less than 65, so that is not good. So that can lead to increased confusion, multi-organ dysfunction. We're going to tick it. Elevated liver enzymes, liver giving problem, tick it. Hyperglycemia, give it a tick too. Respiratory alkalosis, imbalance, tick it. Low platelet count, tick it. So select all that apply. Okay, so that's what I was saying. That little tick here, hyperglycemia, I wasn't really too convinced regarding it. This hyperglycemia. So all of those are suggesting, you know, suggesting for, and respiratory alkalosis is not on it. So respiratory alkalosis, so A, B, C, F. Let's look at what the rationale. So MODS, multi-organ dysfunction syndrome. You have CNS decline, refractory, hypotension, liver failure, and thrombocytopenia. Hyperglycemia and respiratory alkalosis do occur in sepsis, but are early signs, not MODS. Okay, okay. So let's look at them. So the increased confusion, the MAP less than 65, elevated liver enzymes, and the low platelet are multi-organ dysfunction. Okay, so the brain, liver. So let's look at multi-organ. Let's look at MODS a little bit. Multi-organ dysfunction syndrome. Let's look at it. It's a progressive failure of 2 or more organs due to uncontrolled inflammation, poor perfusion, and impaired oxygen delivery. Okay. Okay. So organs commonly affected, NCLEX favorites the lungs, kidneys, the liver failure, cardiovascular, the brain, and hematologic system. Okay. Alrighty. Let's do, where are we now? Number 5, then one more question to go. Sarah, ABCF, ABC, hyperglycemia and respiratory alkalosis are not a part of MODS. So it's a part of early sepsis, but not a part of multi-organ dysfunction. So let's go on to 5. Which actions should the nurse take when administering norepinephrine in this client? Select all that apply. So remember, the patient we're talking about is this one. Confused, disoriented, cool, mottled extremities, capillary refill greater than 4 seconds, dry mucous membrane, urine output of 15 mils per hour. It's dark and concentrated. Blood pressure is 86/52, respiratory rate 28, sat of 90, and temperature of 103.2. So you have this patient who is cool, mottled, confused, capillary refill of, greater than 4 seconds. Now you're going to be given, you're answering question 5 here. Question 5. So which action should the nurse take when administering norepinephrine with this, in this client? What kind of drug is norepinephrine? What kind of drug is norepinephrine? So Sarah, it's actually streamed on YouTube now. So as soon as I'm finished with the live, the video will be available on YouTube at ThinkNursing. So it's a vasopressor. Okay. So what action should the nurse take when administering norepinephrine? Now what we know about vasopressor, it's a very potent drug. What we know about it when it comes on to your organs that are, when you have, especially, it dilates the vessel. No, Sarah. Increases heart rate, blood pressure. So it constricts, so it pulls. Just think of it, say it pulls from your smaller vessels, organs, and then heavy hitters. Yes, Miss Pretty Poodle. So it pulls from your fingers, your toes, and go to your main organs. Get blood perfused to your major organs, your kidneys, your brain. So those, your fingertips, your ears, can get cold because it's not getting good perfusion there. Because what the body is doing is compensating. It's compensating and trying to protect those major organs during those times. So when you're administering norepinephrine, there is a high risk for ischemia. So you have to be very, very careful. So select all that apply. Use a central line if possible. Monitor extremities for ischemia. Titrate to maintain a MAP greater than 65. Give a fluid bolus after starting it. Monitor urine output hourly. And stop immediately if blood pressure rises slightly. So you're going to be selecting which answer. B, E, F. Monitor extremities for ischemia, definitely. Titrate to maintain a MAP. So A, B, C. Use a central line if possible, definitely. Then we say C. Titrate to maintain a MAP greater than 65, because now you know that the patient is perfusing well. Good. Give a fluid bolus after starting it. Why would we want to give the fluid bolus? Because before you start the norepinephrine, you'd have probably given the patient tons of fluid already, right? And the patient didn't respond to it. So why you want to give fluid again? Well, more than likely the patient is going to be on fluid, but why would you want to be giving a bolus fluid after you start norepinephrine? So I would put a question mark beside D. I haven't seen anybody with D. E, monitor urine output hourly, definitely, because they want to make sure that that kidney is being perfused. So as I say, it's a medication that is going to try to protect the major organs or perfuse. So it's going to pull blood from everywhere else and try to get those organs perfused. So you want to monitor your urine output. What is the importance of having urine or monitoring your urine output during these times? Why would you're going to be very, very good with monitoring your urine output? Why are you monitoring your urine output? Kidney function to see if there's dehydration. So you want to see if, exactly, John, perfusion. You want to make sure that the patient is perfusing. You have good perfusion taking place, because if this patient was dry before, there was no blood, the patient is in septic shock. You're giving norepinephrine to help with the blood pressure. So obviously the blood pressure was so low, not responding to fluids. You give all of these fluids and the patient is not putting out any urine, or the patient's blood pressure is not going up. You want to monitor the urine output hourly to ensure that your kidneys are perfusing. So once you have your urine output, you know that the work that you're doing is good. Okay, so you monitor your urine output hourly. Stop immediately if blood pressure rises slightly. Do you stop it if it is rising slightly? Oh, you don't stop it immediately. No, you're not going to stop it immediately. Let's move on to the answer. Oh, hey, hello, we're wrong. We're wrong with F. Let's look at what it says. We don't stop at, yeah, that's exactly Nislene. You taper it down slowly, but we don't really stop it immediately if you start seeing the blood pressure rising. So the answer A, use central line. So, okay, so which action should the nurse take when administering norepinephrine? So which action should the nurse take when administering? So if we, when you look back at the answers, then it makes sense. Which action should the nurse take when administering norepinephrine in this client? Yes. So we don't stop it. We don't stop it immediately if the blood pressure is slightly rising. You're tapered down. So that is still, choosing that answer. Not saying it's correct for this scenario, but in real world, when you're trying to discontinue your medication because you're having good effect, you taper it down. You don't stop it immediately. But based on what this is saying, which action should the nurse take when administering? So you're giving the medication. You're gonna do the central line if possible. Good. Monitor extremities for ischemia. You're gonna do your MAP. We're not going to be doing any fluid bolus after starting it, because we already established that fluid bolus that the patient was getting before is not effective. So that's how we ended up going for norepinephrine or the vasopressin. Then monitor urine output is very, very important as it relates to, your norepinephrine or your vasopressin. Then stop immediately is definitely out of it. So Vasopressin, central line, monitor perfusion, titrate, map, track, urine output is very important. Bolus before pressors. Do not stop for mild blood pressure changes. Alrighty, so that's that. And then final question for tonight. Which findings show the client is improving? Select all that apply. So your lactate drops from 5.4 to 2.1. Is that something good? Your lactate was 5.4. 2 hours later you did it and it's 2.1. Still a little bit bump, but from 5 to 4, not bad. Your MAP increases from 58 to 70. Urine output increases to 35 mils per hour. Heart rate increases from 128 to 150. Temperature rises to 104. And the mental status becomes oriented times 2. So which finding shows the client is improving? A is good because the MAP is, the lactate is going down. So that is good. Your MAP increased from 58 to 70. That's perfect. We want it to be anywhere over 65. Urine output increases to 35, which is good. We want it to be above 30 mils per hour. Heart rate increases from 128 to 150 is bad. All right. Temperature rises to 104 is out of it. And then the mental status, oriented times 2. Let's see where the patient was at before. So the patient, home with fever, confused. Didn't say times how much, but disoriented. Okay. So now the patient is oriented times 2. I would say that's a plus, right? So let's go back to that answer. So A, B, C, F. So A, B, C, F is correct. Kevy, welcome, welcome, welcome. So lactate dropping. So the heart rate and the temperature that is still elevated is not showing yet that the patient is improving in those aspects. All right. But the others are definitely big improvement. So when you have better, that's why I say the urine, when you have urine output, you know that the patient is perfusing well. So better perfusion, the MAP is increased, urine output is increased, your lactate is going down and mental status improving. You're doing a wonderful job as a nurse. Heart rate is rising and the fever rising is indicating worsening. Okay, so that is indicating worsening, but you'd already have your antibiotic on board. So hopefully that should be, making a change here. And your heart rate is more than likely responding to everything that is going on. Everything that is going on. And the fact that this patient has a fever as well. Okie dokie. So yeah, so that's the end of the few questions for this live. So I'm gonna put this one for next time. Yeah, and then from there, all right, guys, how was the live? How was the live tonight? I will be back on, when may I come back again? I will be back on Tuesday or probably Monday. Yeah. I'm going to try to finish my hair 2 nights in a row now. I'm going to try to finish my hair, and I'm not start it yet. But I'm going to try to finish it over the weekend. So on Monday, hopefully, I'm not going to finish because I still have it to wrap. I'm trying to do 4 locks. But probably Monday evening. I normally do my live on Tuesdays and Thursdays. Tuesdays and Thursdays at 7 p.m. Central Standard Time. If I have the time on Monday, I will be popping on for an hour. It was nice HG Fire, welcome. Thank you so much. Thank you. Thank you. Remember to go ahead and subscribe to my YouTube page at ThinkNursing. The full live streams that we do are posted on that page. So feel free to go over there and look for the live. And you can watch the videos over there at your own convenience. Thank you so much, Britt. But you will like some of these questions are, they're a little bit technical for you guys, I think. Some of them. But it's still knowledge. And at least we go through the plan of care, like the management. So, yeah. Joe Otio, welcome. So Tuesdays and Thursdays, I will try my best to make sure that I put it in the, where they do the live. I'm still new to TikTok. I'm still learning TikTok. So please bear with me. I will try to put it in my stories that I'm coming on live, tonight. And I'll try to post it as well. Not a problem, not a problem, not a problem. Stella, you're welcome. So I'm going to go and finish up my notes and then go to my bed. Yeah. I don't know if I'm not going to do any live in the ending of December. Because I plan on going to Florida. Plan on going to Florida for that week there. So as long as it's not snowing in the other, because I'm doing a road trip. I'm doing another road trip. So as long as it's not snowing, not me driving though, but as long as it's not snowing, then yeah, I'm going. Okay, Fran, congratulations. Congrats. So Fran recently passed NCLEX. I would love for you to join us. Come and join us and, share some of your knowledge with us. Yeah. All right. So I'm going to go now. So enjoy your night, guys. And I will see you in the next live. Okay? Yeah. Guy that makes football edits. Welcome, welcome, welcome. I am actually ending. Yes. Good night to you too. All right. Bless up yourself, HG Fire. Where are you joining in from, HG? Are you from Yard? Because I say bless up. Oh, yeah. Because we all alone, most of us just say it, bless up, wagwan. Sometimes I'll see the name and I'm like, yeah, that's a Jamaican. Yeah, that's where I'm from too. Oh, they left. They left guy that makes football. They left. Oh, Brit here in Jamaica as well. Yes, we're in Jamaica. You guys' family weren't affected by the hurricane. And which school you're going to? Which school you're going to? Which school you're going to? Yes, he is. I went to NCU. Anybody here from NCU? Going to NCU? I'm not Jamaican. I'm Bayesian, but I love... Oh, okay, Brit. Me should have probably said it because when you put it in a quote unquote, big up yourself. Most Jamaicans now come and say quote unquote, big up yourself. I'm just going to just big you up. You understand? So when I see you put it in quote unquote, I say, is she a real Jamaican? Yeah. All right. But thank you, though. Thank you, thank you, thank you. All right. So I'm going to go now, guys. Enjoy your evening or your night. All right. And stay safe. All right. Guy that makes football edits. How are you? I don't know. Most of the time, persons just passing through. Like, they will be on the live for probably like a few minutes and then they just leave. So initially when I just started around, because I started around 7 o'clock. When I started around 7 o'clock, there were like about 14 persons. Then they left. Then there were like 9, 15. And then they just left, come back. So it is what it is. As I say, my content is not what a lot of persons probably are interested in. Hopefully one day I will find persons just hanging out on my live stream every day with me while I'm sharing the content. So It's just a thing. But I still keep posting because there are persons out there that need the content. So at least one person, it will reach one person. That's it. That's just it for me. But I'm enjoying it. So whether or not anybody shows up, it's just gonna be there. It's free content. It's gonna be out there for somebody else. All right. But in the meantime, I am gonna go. So enjoy your evening. Whenever you're watching this, thank you so much. And remember to go ahead and tune in. Follow me on TikTok at ThinkNursing, and also subscribe to my YouTube page here at ThinkNursing, where I share long form content. Until then, peace out. Bye. Oh, bye.